Hi everyone, Lijo here. I'm the co-host for the webinar. So in another 1 minute we are going live. So I just give you a clue, Radhika ma'am. After a minute, after a second, few second, 2 3 second, you can start your speeches.
Sure, sure.
Yeah.
Thank you. Good evening and welcome all of you to Onia Clear, the Shankar Netralia Keratitis webinar. This is a one-of-a-kind interaction between the Onia faculty at Essen and its awesome alumni. We have lined up some day-to-day cornea cases for you, but ones with a slight difference in approach and management. Today is also the day we cherish the memory of our beloved Dr. G. Sita Lakshmi. I now invite Dr. Rama Rajagopal, who heads the cornea team at Essen, to declare this meet open. Dr. Rama?
Good evening, everybody. On behalf of Shankar Netralaya and the Cornea Department, I'm very happy to invite you all to this SN Keratitis webinar. Like Radhika said, today happens to be the Remembrance Day of our beloved teacher and mentor, Dr. G. Sita Lakshmi. Dr. GS, as she's fondly called, is truly an inspiration in many ways to most of us who have gone through a training in Shankar Netralaya under her guidance. So we invoke her blessings today at the beginning of this event. Radhika has put in a lot of effort to collect all these interesting cases and put this show together. So over to Radhika now to initiate the program.
Thank you, Rama. So before we start, let me quickly introduce our distinguished panelists for the day. We have Dr. Rishi Swaroop, who is a cornea all-rounder. And he's certainly the man of the moment in the present COVID cornea webinars. And we also have Dr. Rajesh Hogla, who doesn't even need an introduction in these circles, simply because over and above his many credits, he is probably the best pair of surgical hands in cornea in this side of the world. And he had a personal emergency today, but still could join us, and we're truly grateful to him for that. Rajesh and Rishi are illustrious SN alumni. And so what more can I say than welcome back home?
Thank you,
so we start the evening, hi. So we start the evening's presentation, the first case being a bold presentation by a bold presenter, Dr. Ramya Ravindran, who's also the recipient of a recent Academy Award, not the motion picture, the AO. And Ramya is going to take us through the course of a complicated corneal ulcer and how she conquered it. Ramya.
Thank you, ma'am. After that introduction, I'm not sure if I can do justice to this. Thank you so much for giving me the opportunity to present my case today in this forum. So this is the case of a corneal ulcer that melted on my watch. So on day one, I had a 40-year-old male who presented with one of those extremely innocuous looking ulcers that doesn't worry you at all. It is a 1 into 1.5 millimeter infiltrate. AC was absolutely quiet. There's a bit of redness. I scraped it anyway and I sent it to microbiology, and they weren't too sure because my yield was kind of a little on the lower side, but they said it was possible that they saw gram-positive cocci. So now I was even more complacent and I gave him topical moxifloxacin 6 times a day. And maybe my complacence rubbed off him and the drop was a little expensive because he did not end up using the medications. Then he turned up after 24 hours and with a full-blown ulcer, for the melting cornea. It was about 7 into 7 millimeters in size and a 1 millimeter hypopyon, and this was within a span of less than 24 hours. And I had all my cultures show Pseudomonas at this point, but I didn't need the cultures to tell me what I already knew when I saw his eye, that I had missed a gram-negative infection. I started him immediately on fortified amikacin, homotripin eye drops, and I admitted the patient. But after 24 hours, the ulcer continued to melt. And at that point, I used cyanoacrylate glue and a bandage contact lens in place. And I also started him on topical corticosteroids with a bit of apprehension, but it was after 24 hours of intensive antibiotic therapy. And the antibiogram, which came after 5 days, showed sensitivity to all the first-line drugs. So 24 hours after I had started the steroids and used the cyanoacrylate glue, the hypopyon was gone. The melt had completely, the ulcer had stopped melting because the glue was very much in place. The patient felt so much better. So I was quite happy, and I continued the steroids and tapered the steroids, and while he was continuously on the antibiotics. But by 3 weeks, I decided to remove the glue and PCL because I originally used them because of a melting cornea and I wanted to buy time, not because of the duration of the disease. Once I removed the glue and PCL, the ulcer was still active and
It's now in gallery view only.
So I tapered and I stopped the steroids and I continued the antibiotics.
Got
He
it.
scarred quite well by around by day 30, day 35. He had completely
Actually,
scarred,
my
but
settings
I
is
found
changed.
a little dense
That's
for my
our
liking,
problem.
so
I fixed it.
I
Fixed it.
did
Not
restart
issue.
a soft steroid to
Yeah.
see if scar remodeling would happen and
Okay.
it reduced intensity of the scar. I don't know if that was a particular cause, but by day 68 of 2.5 months in place, this is how he presented the last picture. His vision was 6'9" with glasses. And this case taught me a couple of things. One is that even though steroid is a double-edged sword, sometimes in aggressive bacterial ulcers where the immune component is very strong, you may need to use it to stop the inflammatory part of the ulcer. The tissue adhesive was removed way earlier in this case than I normally would because I did not want to have a vascularized scar. And saving the globe is the primary concern in any infection, but very close on its heel is also to give the patient the best possible visual outcome as well. That's it, and thank you very much.
Thank you, Ramya. Can you take down your presentation? So we have two discussants for this case. Both of them are senior consultants at Cornea SN. Dr. Nivedita Narayanan and Dr. Meena Lakshmipati. And as far as treatment of gram-negative corneal infections goes, we have a gamut of medications across a spectrum. On the older end of the spectrum is probably fortified gentamicin. And I have seen some cases of Pseudomonas ulcer just fade away the face of gentamicin, ones which look very dangerous to begin with. And if the sensitivity allows, then fortified garamycin still would be a go-to medication for me. So, Dr. Nivedita, what do you think about the medical management that was done in this case, the antibiotic as well as the use of steroid? Would you do it this way or would you do it differently?
Thank you, Radhika. I am also a fan of gentamicin. I have treated many Pseudomonas deadly-looking ulcers with gentamicin, and fortified gentamicin really works well. Sometimes the ulcers are not really so big. Even fluoroquinolone, ciprofloxacin with intensive medication also helps. Though there are a lot of strains which are resistant to
Rahul, who is speaking?
overall,
His video is not coming.
Ciprofloxacin is variable.
Who is speaking
So in
now?
my
Her
hands,
video
I
is
have
not coming.
treated many cases with ciprofloxacin intensive medication also.
No, the speaker,
But
one
what is
doctor
very
is speaking,
interesting in
but her
Ramya's
video is not there.
presentation is her concurrent steroid use. Though
that I
there
removed.
was a gap of a day or so, as she says, after the intensive antibiotic.
Sorry to interrupt you for a minute. Can we have your video on screen? The audience would like to see you as well.
Okay. Okay.
Yeah. Can you see me now?
Yeah.
Yeah, sure.
Yeah. So, in this case, what was
Yeah.
interesting is the way in which the
Yeah,
steroid
yeah.
was
Okay, I'll try.
used. Initially, in the active stage with the melt, which required, according to Ramya, a glue BCL. And then boldly she went ahead and started the patient on steroid. As she rightly mentioned, it's a double-edged sword where it can also increase the melting. It can also delay the healing. If when we talk about Pseudomonas, there are two different varieties overall. One is a cytotoxic, highly virulent variety, which will melt the cornea in no time. The deadliest, probably those publications where Pseudomonas have been always portrayed as the worst to deal with and with poor visual outcome, always needing surgical intervention, will be probably that type. There is another type which is not so virulent, not cytotoxic, but that goes and invades the cells, the epithelial cells mainly, and it sort of evades the antibiotic, whatever that we use, but at the same time, it doesn't cause a melt that's severe. But what it does is it causes a lot of immune reaction. So there is some kind of overwhelming stromal changes, which can sometimes mask as a melt, but that beautifully responds to steroid. Literature has supported the use of steroid in this particular variety. So I suspect that probably her luck in this case could have been that sort of a variety where the overwhelming reaction was actually not a cytotoxic melt. It could be an immune reaction that responded beautifully to steroid.
Right. So your message is that the type of Pseudomonas could decide whether the steroid would benefit quickly or not. Dr. Meena, on the other end of the spectrum of medication that we use for gram-negative infections or Pseudomonas in particular, we also have the higher concentration levofloxacin now of Tuckwix, no financial interest here. So even though it's an older generation, it's touted to be a stronger concentration and supposed to be more powerful against these deadly gram negatives. So though we have not really used them very much, what are your thoughts on these recent higher concentration medications? And the treatment-wise, would you do the same as the previous two people, or do you have any new points to say?
First of all, I'd like to tell Ramya that very well managed, because although she has seen a 1 into 1.5 millimeter size ulcer, she has gone ahead and scraped it. So never underestimate the power of ulceration. So with that only, she was actually able to go ahead. So although we know that less than 2 millimeter any ulcer, we don't have to scrape, and we can give broad spectrum fluoroquinolones, your scraping actually was very, very helpful. For fortified fluoroquinolones, it has been shown in the ASIC study that 1.5% levofloxacin was very useful in Pseudomonas, but particularly in certain countries of the Southeast Asian population, not in India. So I am not very sure as of now, unless we do PCR based variation, whether we are dealing with a cytotoxic or invasive variant of the Pseudomonas. So I'm yet to be very, very confirmative. I cannot at this point give you a proper response. But 1.5% levofloxacin, I will still use it for gram positive and use fortified medications for amikacin, fortified medications for Pseudomonas, because the faster you deal with it, you literally have to hit it very, very hard, because it has a very propensity to cause host defense mechanism, which is literally seen by the ground glass appearance. So you need to handle it very, very quickly.
There's no room for speculation. That message is loud and clear. So, Ramya, before we move to the next case, I have a quick question for you. So, when you do glue BCL for threatened perforation, not only it offers tectonic support, glue is also known to wall off the inflammation. It prevents the cytotoxic or inflammatory enzymes from reaching the site of the perforation. You seem to have done the glue BCL and close on the heel started the steroid. And I would still think that part of the inflammation control happened because of the glue. Are you giving more credit to the steroid and taking away some from the glue itself? Or my question is, would you have possibly waited a little bit after the glue BCL to start the steroid?
Ma'am, honestly, I wouldn't know because, as you correctly mentioned, I did do both of it at the same time. But if I could choose to do something differently, I think if I was a little less scared of not having tissue and a patient who had worsened so quickly, so fast, I probably would have started steroids but not glued him at that moment and just waited to see if things settle.
In fact, I was going to ask you what was the feeling at that point. What is the real need to do a tissue adhesive? Should you have waited on it?
So it was on right. I mean, this was a logistic reason. It was right on the heels of the holiday, and the patient was not affording and get
Giving
this.
some tectonic support.
Yeah, so I just wanted to make sure I did everything I could do to make sure.
And like Dr. Radhika mentioned, I think the glue would have helped also to arrest the melt, and we all know that glue has bacteriostatic action as well. So maybe it also helps in controlling infections. Wonderful.
Absolutely. A three-prong effect: tectonic support, a mild antibacterial, and walling off the inflammation. So if I did decide to do the glue, I may not have decided to do the glue, but if I did decide to do the glue, I would have probably given it its time to work before starting the steroid. But then finally, all is well, I think, is that ends well. So moving on, Dr. G. Sita Lakshmi, the lovely lady of our department, went on to become the first woman in the world to do the daunting surgery of MOOKP. She trained many cornea fellows, and we have one of them over here, Dr. Priya Srinivas, a bright fellow then and a senior consultant now. Priya is going to share with us a set of difficult peripheral ulcerative keratitis, one of whom is an octogenarian patient. Priya.
Thank you very much, ma'am. Let me just get to slide share. Yeah, is my slide seen?
Yes, Priya.
Yeah. A very good evening to all of you. It's so nice to reconnect with you, SN alumni. Thank you, Dr. Narman, for this wonderful opportunity. So without much delay, I would like to present three cases of peripheral ulcerative keratitis, which seemed difficult and daunting to me, and which recovered and taught me some lessons along the way. The first case was of a 70-year-old lady who was referred to me by a general ophthalmologist colleague with a corneal infiltrate which was there for 6 to 7 days before presentation. So this was a corneal infiltrate which looked which had no epithelial defect, but it had a florid kind of an appearance with some amount of adjacent scleritis. Because she had a history of rheumatoid arthritis for the past 20 years and she was on methotrexate and some low dose steroid, I had an immune infiltrate because of rheumatoid arthritis as the very first diagnosis in my mind. But just to rule out an infection, I did a corneal scraping, which expectedly turned out to be negative. So I put her on topical fluorometholone eye drop. However, this didn't give much success in the next 3 days. Her symptoms came apace. So after discussing with her rheumatologist, I just increased the dosage of oral prednisolone to 1 milligram per kg body weight, which was 60 milligram, and I decided to taper it over the next 6 weeks. She phenomenally did very well after I started her on oral steroids at this dose. And her infiltrate resolved to a large extent at the end of 7 to 10 days, and within a month was completely clear. Ever since then, she has been under my care for the past 7 years. Barring a couple of mild recurrences, she never had any problems, and she continues to do well with lubricant and she continues her systemic therapy for rheumatoid arthritis. Moving on to the next case, this was a boy who was an 18-year-old male who was seen by my earlier colleague for about 4 to 6 months, and he was treating him with soft steroids for some marginal keratitis like this. This was affecting.
Hello, sir. Sir, I think you are very busy. Oh, is it? Okay. Sir, These guys are telling they need a one more shareable link to everyone. Yeah, that's what. Yeah, yeah, that's what I'm telling them. Yeah, definitely it will get lag. Mm. No, for tomorrow you are giving us two IDs, right? They give. Yeah, no, 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 not for interface with the. Everything is interfacing with my system only. For a TV they need one ID, no? So it has to connect it separately, like okay. Before start, you share with me. Hmm. Okay. Yeah. Okay. We test it. Okay. Okay. So this. Okay. If we given them, that's what, simply tell them to do the streaming, sir. You know, sir. No, 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 no. I'm not a sir. Will I do? Do you think I will do that? Okay. Okay. Sir, I'm trying to connect one more laptop. No, no, that and all I will do it. Not a problem. So I need one more ID. Okay, to the lap system LED TV there. No, I was only. No, in Ballari, what happened? No, in between someone, the ID which I logged in, no, same ID somebody logged in. I lost the connection. That happens, sir. Sure, sir. Sure, sir. Tomorrow? Okay. Yeah, yeah. I please share with me too, because of the TV I have to connect. That two thing is and mine. These two are major. Okay. Okay. By 7 I reach, sir. Same like Ballari. By before 9 o'clock I will be ready with everything. If you give the connection, we can. Okay. Okay. Okay, sir. Okay, sir. What about the video? Did they did or what? Okay. Yes. That then. Yeah, yeah. Rahmat, I'm coordinating it. Okay. Yeah, yeah. Okay, sir. Okay. Okay. No, 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 no. I'm leaving tonight. I am in the event in between. One Zoom conferencing is going on. I finish this and night only I leave. I will go there and take rest. After that, or else I cannot manage these people. Yeah, yeah, yeah. I do. Yeah, 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 yeah. Yeah, yeah. I'm. Okay, sir. Okay, 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 sir. Mm. Mm.
immune process. Do you think it was an epithelial defect which was caused by her fingernail, which was left unattended? Because the circumstances were not conducive, age, less tears, poor blink, poor attention to the problem, all that led to the dreaded complication of an epi defect leading to a PD and a melt? Or was it simply trauma because you tried, suturing something which looked like a linear tear later? So, which do you think fits the diagnostic bill the best?
I believe
Hello?
possibility
Yes, Rahul.
of that this being an
Remove
epithelial defect
Rahul.
which didn't heal because of her poor ocular status and unattended ocular condition, and probably the
My
lubricant might
audio
have
is
been
unmuted.
that could be and an ongoing stromal bed subsequent to the episode
Right.
is the only thing which comes.
Right. Even I thought so. So to discuss this case,
So
we have
mine
with us
is
Dr. Mamta
no,
Agarwal.
it's mine is mute
Mamta
only.
deals with cornea as well as uveitis patients. So she's an authority on immunosuppression
Okay.
because she deals with the problem at both ends. So Mamta, for PUK, we normally give
Yeah.
immunosuppressants for chronic problems or less severe problems and cytotoxic agents
Yeah,
for
okay,
the
okay.
more severe problems. So in extremes of age group, even if we thought that the elderly lady had an immune problem, would that kind of immunosuppression be easily applicable? Would we get a clearance for it, or how would you go about treating these patients, especially in the extremes of age group?
Hi, Priya. That's a really nice and real challenging cases. Am I audible?
Yes, Mamta, you are.
So I would just say that it depends upon the clinical condition. That if we need, yes, we can give these immunosuppressives, and intravenous methylprednisolone is our first choice actually in these cases. And if not, then we can also go for pulse. But then pulse, we haven't. I don't think I've ever given pulse to this kind of an age group, pulse cyclophosphamide. And plus, when the diagnosis is not so sure, so you would be a little hesitant in your last case. But if it's a rheumatoid arthritis or it's a GPA or any other collagen disease, I think. But it's always with a consult to the rheumatologist when I have to give an IV cyclophosphamide. And IV methylprednisolone, yes, we have physicians who can do. But when we have extremes of ages and cytotoxic agents, we do consult. But endoxin tablets, yes, we can continue because the most common risk what we know of is bladder carcinoma and sterility. So it's always better that we consult these patients. But I think these drugs are actually being used for years together now, and it's okay to use. We should not be really scared of using if we have an internist with us and be careful about the infections and herpes and tuberculosis, which is more predominant in our part of the world.
Right. So if all the confounding factors are taken care of, age probably is not a bar to immunosuppress them and save the eye is your message. How about biologics in extremes of age? Very small children and very elderly, is there a catch to using biologics again with the same conditions that you put now, or would the
biologics, like we have what we call adalimumab, which is the FDA approved in children, and we have like enough experience in JIA patients where we have them on long term. The only thing is we have to really be very, very cautious because there have been results of tuberculosis and herpes, which is more
especially in this side of the world, yes.
And usually we do not give only for ocular conditions, except for like Behçet's and Murans, which is absolutely an ocular condition. So biologics, I'm not really sure we really need in these conditions because we can very well manage with other drugs which we still.
Immunosuppression.
Yeah.
Right, Mamta. So we also have with us.
Ma'am, just a sec, I would like to interrupt.
Yes,
There's some problem in the viewers. I think they are having some background noise. They're asking to pause. They're not able to hear us, the presentation.
Right. We'll wait for 5 minutes till admin is able to fix it.
Yes. Thank you so much. Sorry for that.
Admin, can you tell us when you're able to fix this problem?
Mr. Raman, if you're there,
you keep a tab on that, Aditi, and let us know when it is fixed.
Yes, ma'am.
Can I ask a question while we wait?
Okay, yeah. But we are not audible to them. That is what they're complaining.
If you can save the question for 5 minutes, then you can partake it with the viewers also, Rishi.
Okay. So just 5 minutes.
Hello?
Because we are getting a lot of complaints. Mr. Raman, are you there?
Any problem with the audio?
anyone from Intod?
Uh,
Mr. Rahul?
ask, can you speak to them? They are speaking to you.
There is a background noise coming from the technical team. Somebody talking on the background.
Yes.
No, what type of background noise? Because we are only two persons, Lizo and me, from the technical team. Rahul and Lizo. We both are on muted.
What I suggested, sir, if you can just go and check the viewers link because so many people are complaining, so there must be some issue.
Yeah. Aditi ma'am, I am just checking because from my side it is already fine. Okay, and everybody is seeing the webinar on Facebook and YouTube already.
Okay. But,
And everybody is commenting also. Okay, and I think that when your turn will come, then please unmute yourself. Okay, otherwise mute yourself. Okay, because I think that from some two persons which I muted, I don't know the name, I muted in between the webinar. When your chatting is coming on WhatsApp group now, then I muted that. I think that that's Mamta ma'am and one on another also. Two ma'am was there. Okay, I muted them. So that's why when your turn will come, please unmute yourself. Otherwise, mute yourself. Okay.
is there someone Mr. Lees over there? Actually, our fellows are texting because they can hear the voice. Can you
No
please
problem.
check one?
No problem. Go ahead. I will take care. Okay.
Yeah, we can just have a run. I'll just ask them whether they can hear us, then we can start it.
Rahul, you can make the co-host to Aditi ma'am.
Yeah. Wait. Yeah. Sure. Yeah, ma'am.
Overall, here in this group are only part of the faculty team, right? We don't have anyone else.
And I make the co-host to Dr. Nishant sir also. Okay.
Yes.
Yeah. No problem.
Nishant,
And
mute all of us. Mute all of us.
okay. And
Even
so
the.
I'm also taking care. Personally, I'm taking care. Okay, ma'am.
Thank you so much. I'll just. Okay. But 5 minutes, can we just do a trial and we can get back from our fellows?
No problem, ma'am. Go ahead, ma'am. No problem.
Yeah.
You say hello to the fellows.
Yeah.
And ask them if they can hear you.
Yeah.
Without the background disturbance, and then we'll go on.
Just. Hello. Just text me. Am I audible?
Yeah, you are audible to me.
No, not. I'm asking the viewers.
Oh, sorry.
Responding.
Sorry. Yeah, it's a real.
Yeah. Am I audible?
Yeah, you are audible to me.
No, not. I'm asking the.
Please, those on this link, don't answer her. She's checking with the viewers through the viewers link.
एक और प्रॉब्लम आई थी बीच में अदिति मैम कि व्यूअर आपके कुछ पार्टिसिपेंट व्यूअर लिंक को भी ओपन किए हुए हैं तो वो बैकग्राउंड में वो भी साउंड आई है रिपीटिंग साउंड ओके सो प्लीज डोंट ओपन द व्यूअर लिंक एनी पार्टिसिपेंट प्लीज डोंट ओपन द व्यूअर
Okay, just one thing. What they are saying is they can only hear the team. Can you just check on that?
Rahul, can you do one thing? Just record from the back end and put it in the group.
Yeah.
We can continue.
Personally to me also.
Yeah, sure. And request to all participants, please don't open the.
Go ahead.
Yeah, go ahead, sir. Go ahead.
Can we proceed with the webinar? Or do we wait?
Ma'am, just 2 minutes.
Okay.
Just 2
Whenever
minutes.
you say.
Yeah, they are just getting our fellows are just checking it.
Aditi, the minute Mr. Rahul Jain unmutes himself, we can hear the background voice.
Sure. Mr. Rahul Jain, are you there?
Yeah, ma'am. I'm always here, ma'am.
Okay. Can you just mute yourself? That is what we are getting.
I was already muted. I was talking to you when
I know. Even the mouse clicks.
Yeah, because after 10 seconds you are viewers seeing is after 10 to 15 seconds you are seeing the webinar. Okay, there are delay of 10 to 15 seconds. Okay, ma'am.
This is it. Okay, so just last 2 minutes and we'll get back. Okay.
Yeah, sure. I muted myself. Okay.
So am I audible? we are better now. Ma'am, I think we can proceed.
Okay, right. It's better now. The connection is better now.
Yeah.
Noise is less. Okay. So we just left off where Mamta spoke to us about the use of immunosuppressants and the use of biologics, and she seemed to think that with the proper precautions and everything in place, age is not a bar for immunosuppression. And biologics, she wouldn't really employ unless it is absolutely required, because we can manage with immunosuppression for PUKs. The next discussant for that particular case is Dr. Pratik Gujar. Pratik is our ex-fellow and an excellent surgeon, cornea surgeon. So, Pratik, the cases that Priya described, surgical management, what would yours be? And the last patient, because of age and because of not knowing exactly what etiology it was, I might have thrown in a tarsorrhaphy. Would you?
Thank you, ma'am. Yeah, definitely. Am I audible now?
Yes, now, Pratik, yes.
Thank you, ma'am. Coming to the surgical management of these cases, definitely I would owe something to RR Madam, who exposed me to the initial management of these cases surgically. I remember when I was under posting, we managed a case of bilateral aggressive Murans, like Dr. Priya presented here in her second case. But unlike that case, our case was a bilateral, very aggressive young male, and the case was very aggressive in nature. So we did a conjunctival resection in that case along with amniotic membrane transplantation. Later on, even with the systemic immunosuppressive and this surgical procedure, the case progressed, and we did a glue PCL. When 1 month later, the case again progressed and required a crescentric lamellar patch graft. So it's always like this stepwise approach that we had to adopt in these cases. Fortunately, in the second case, which the man presented, we get off with just blue PCL and systemic immunosuppression. But in young bilateral patients, sometimes the case is more aggressive, and you might require the conjunctival resection as well in the initial cases. Coming to the third case, which ma'am presented, I think I would have also done punctal occlusion for that case, along with the management, because I'm not sure about the exact etiopathogenesis of that case. And yes, you rightly pointed out tarsorrhaphy would have definitely helped in that case, because you need not to do an extensive surgery, and you can definitely preserve the globe integrity. So yes, along with tarsorrhaphy, punctal occlusion, I would have preferred to do.
When you do lamella patches or pathetic patches for PUKs as tectonic measure, how do you size the graph? Do you use a stencil technique, or you just visual measurement is what you use?
Yeah, basically, I would like to be as close lamellar as possible. Try to avoid penetrating keratoplasty, and I use two trifines. First, I use 11 millimeter or 10.5 millimeter trifine to just mark the outer boundary after doing conjunctival peritomy of the recipient bed, and then depending on the depth of the level of involvement, the inner marking I do with 8.5 or 9 millimeter trifine.
Right. And so two convex cuts which join form the right, Pratik. So now can we have the panelists coming in, Dr. Rishi and Dr. Rajesh? Can you offer your comments on both the cases, the melting pseudomonas and the PUK? I keep going back to the elderly PUK.
Rishi sir, you have to unmute.
Thank you, Dr. Radhika. Both the cases were very interesting. Ramya's case is also very interesting, because small, seemingly indolent ulcer became full-blown pseudomonas, and I think she managed it perfectly. My only question was, your sensitivity was only to the quinolones, isn't it? Was amikacin also
sensitive to amikacin also? It's sensitive
to
all the drugs, but I got sensitivity after 5 days. I started on amikacin.
So typically, in my understanding, I only start steroids once I have a sensitivity in a bacterial keratitis. So that might have been a little bit of a risk, but I think this particular case, it was going steroids. I think was definitely a was definitely called for, and especially Pseudomonas keratitis, we know the melt is largely immune. So I think steroids were perfectly okay, and removing the tissue adhesive early also was probably quite prudent because it avoided getting too much of blood vessels in. And like you had put it mainly to just stabilize the surface and arrest the melt, not really for tectonic purpose. So I think that was a very good approach, and congratulations on a very good outcome.
Thank you very much.
As far as the second presentation by Priya goes, the first two cases, of course, were quite straightforward. But I have only one question for the first case. Why did you have to think of an oral prednisolone? I think this might have been managed quite well with topical prednisolone as well. You had just tried surface steroids. If you had tried a prednisolone topically, I think that would have done the trick. And you could have avoided giving a systemic steroid. Of course, it might have helped the systemic status as well. But I feel that you could have tried a prednisolone first, and if that didn't work, you could have gone to an oral steroid.
Sir, could you be kindly a little bit louder? A request from our audience. Thank you so much.
Yeah, point taken. At that time, it was both of us were getting impatient, and it was just a judgment call at that particular moment, and it worked.
Okay, cool.
I'm also in sync with Priya in this, that I believe that any form of PUK, it's a personal belief, any form of PUK, even if it is a mural, which we say is an ocular disease, does have some kind of systemic autoimmunity. And I would also prefer to start the systemic steroid in a case like that.
Sure. Yeah. And anyway, you have discussed with the rheumatologist, so that's perfectly okay. One more thing, in the third case, your ESR was elevated and rheumatoid factor was elevated. So why are you thinking of like a sterile melt from epithelial defect? To me, it seems more inflammatory.
The central melt, that's probably what led to the diagnosis. Was it Priya? Because you don't get like that in rheumatoid, right?
The pattern of ulceration, the location was not somewhere fitting in the general PUKs that seen. And again, I still don't know, as Dr. Radhika mentioned, that could be one cause, but
the reason I felt that it could be an inflammatory cause is because the surrounding cornea was actually very quiet, like you would get in a rheumatoid melt. Otherwise, if it was because of a epithelial breakdown and because of that, the adjoining cornea would show something. That's what I felt. Maybe Dr. Fogla can add.
Yeah, I think most of the points have been covered quite well. The third case, if you look at the location of the perforation, it's somewhere in the area of the palpable fissure, the exposure area. So if she had some underlying aqueous deficiency and you had like a small epithelial defect, and along with that you had the area of exposure, like if she's not completely closing the lid, all these would have accentuated the stromal thinning and ultimately leading to a melt and perforation. So that's where I think, as Pratik mentioned, that doing a punctal occlusion and doing a tarsorrhaphy could have improved the tear volume, and you could have, the eye could have gone better much faster. And regarding the first case, regarding oral steroid, I think Priya mentioned that there was some element of scleritis as well. No. So yes, if you do, she anterior scleritis, and then there was some infiltrate. So if you had scleritis, then that oral steroids, does have a beneficial role in taking care of that. As far as the Pseudomonas goes, I used to be a fan of fortified gentamicin, but I think for me, tobramycin and amikacin kind of is less toxic to the surface. And among the quinolones, I think I still prefer for Pseudomonas. I think I start off with Cipro as well, because in a lot of studies, Cipro has shown to be effective, although we have the newer quinolones. But still, if I had come across that case, I would have started with maybe either fortified amikacin or tobramycin in combination with Cipro. In terms of steroids, that's again something, it's like a double-edged sword. Unless you have a very compliant patient and you can monitor the patient, for 24 to 48 hours after you start with the steroid, I think that's where you can initiate 3 to 4 times a day and see the response, and then decide whether you have to continue with that as well.
Yeah, I think Priya mentioned that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like to emphasize that the steroids, they have a very good effect. But again, I would like
And if there was no significant thinning or there no perforation, I may not have used the glue. But in this setting, when tissue is not available, I think it was a good decision to kind of provide some tectonic support so that you don't land up with the perforation and no tissue, and then that will become much more difficult to manage.
Thank you, sir. I just wanted to say, I think I missed saying this, but I did start the patient on fortified amic acid and ciprofloxacin because, as you mentioned, I did not have an antibiogram at that point in my hand, and the patient was admitted after the ulcer became full blown, so I did have it.
Correct.
That's an
And
important
what was the frequency of, because there is something like a loading dose for these kind of infection. Initially, when you start, you can even give them every 10 minutes for the first 2 hours, so the really concentration.
And then I made it hourly through the night. So that's why I admitted.
The amikacin, you don't really need to continue hourly after that because it's very toxic. So if you use it hourly, it will actually lead to a larger epithelial defect and sometimes produce more. So after the initial loading dose, you can continue amikacin even 2 hourly. That should be fine. You can continue with cipro maybe 1 hourly. So that's how, because sometimes I avoid the medication toxicity as well, because then it becomes difficult to judge which is working and which is preventing the epithelium from healing.
Since we have all the alumni talking over here, I want to also share that my first case of Pseudomonas ulcer treatment happened under the watch of Dr. Rajesh Fogla. I don't know if he remembers it, but I remember it very well. I was a trainee at that point and he had just become a consultant, and it was a ring infiltrate. I scraped the eye and it showed Pseudomonas, and I proudly started hourly medication. I think it was gentamicin at that point of time for availability of not much else. And I called the patient back, a couple of days after that, or probably the next day. So I just wanted to check with him once before I, sent the patient away. And he told me, "What are you doing? Pseudomonas is something that can melt on your watch, and 2 days later is not when you call the patient. You admit the patient, you load the drug, you look at the response, and then only you send him home." And that message is something that I would like to convey in his presence to everybody today, and I still practice it myself. So Aditi is manning the chat box for us, the small and powerful Aditi. Do we have any questions for the panel from the chat box?
Yes, it's now me to have. So there's one question. Any suggestion regarding using of Fevikwik if cyanoacrylate is not available, especially in peripheral centers and during lockdown situation?
It's been reported. People have used the magic glue or Fevikwik when nothing is available. Just that it's the same thing, but it's not, the purity is less. But so don't apply too much. Try to apply just a minimal amount to deal
Now you are getting any disturbance
with that situation. But if you don't have anything, I think there's no harm. So if I was in a similar situation, maybe I would, to save the eye, I would use.
Would it be sterilized in some way, or would it be used just like that?
The reaction that happens when it polymerizes, the reaction when it happens when it polymerizes itself makes it sterile.
Right. So we move on to the next case. We have next with us Dr. Devyani Dhruv. Devyani is a winner, at most things, but specifically at the prestigious ACRS Film Festival this year. And Devyani is going to show us a case which teaches us not to ignore what is obvious.
Thank you so much, ma'am. I start by sharing my screen. It's a sort of a digital homecoming for us, and I'm really happy to be here and thankful for the opportunity.
Okay,
I'd like to directly go ahead and talk about what I'm here for. Hidden in plain sight, for the lack of a better terminology and calling it foreign body induced like this, focusing more on the role of ASOCT and UPM. So talk about three
cases. Can you be a bit
here.
louder, Devyani? I'm not sure it's only me.
Sure, I'll be louder. So I'm talking about three cases here. Commonalities in these three cases have been the chronic presentation. They have been treated with oral or topical steroids elsewhere, and all three of them have had a history of either trauma or surgery. and all of them have been considered for immunosuppression as well. So the first case is of a 65-year-old gentleman who presents to me with this picture. He has a painful nodule in his right eye with a pus-filled center of sorts, and he has had this problem since the past 3 months, has been treated multiple places with oral and topical steroids with antibiotic combination and in various combinations. There was no epithelial defect on examination, and we decided, because we have had these similar cases in the past, we decided to investigate with UBM. On UBM, because of the significant time period as well as the surrounding significant liquefactive necrosis, we were able to see this foreign body very clearly. And on exploration, we were able to remove it and deroof the nodule, treat it like an infective scleritis, and this is at the end of 2 months of intensive antimicrobial therapy. Case 2 was not as chronic. This patient had a history of a road traffic accident 1 month prior, and we saw him like this. The patient insisted that the redness was only after the accident. I understand that not always is the correlation between causality and what we see linear, but this patient insisted upon it, and so I dug further. He told me that the road traffic accident actually consisted of him falling into a thorny bush. And when thorns came into the picture, I decided to investigate further. We did an ASOCT for this patient. To be very honest, there was no clear-cut foreign body seen here. What stood out to me in all cuts of the ASOCT was this broad-based backshadowing, which started really superficially, I would say. There is a episcleral vessels as well can cause this kind of backshadowing, but it's not this broad-based, it's not this superficial. So this kind of made me feel that there was some foreign body that was sitting there. And we did an exploration. We were able to find a sliver of a thorn inside. This patient is on his way to recovery as we speak. Case 3 is a bit different. There was a 45-year-old lady with a history of recurrent redness for the past 4 months. There was no resolution of redness despite both oral and topical steroids, and oculoplastic surgeon was considering immunosuppression. Scared of immunosuppression, she sought a second opinion, and the thing that stood out to me in her complaints was not the fact that she was complaining of pain, which is expected with a scleritis, but of foreign body sensation. And she kept on saying that there's a lot of foreign body sensation. And when I stained her, there was a small epithelial defect at the apex of this nodule. Because I didn't feel that it was, telling me all that I needed to know, so I went ahead and did an ASOCT. ASOCT in all clock hours was really non-specific nodule, kind of with a lot of backshadowing, not much information being given to me, except in this one particular quadrant where I was able to see this, something was protruding out. And that is when I asked her if there was any history of surgery. This patient said she had undergone squint surgery in childhood, and probably the suture was protruding out at that point. Our squint surgeon was kind enough to share this clipping of the video of the suture removal. Here we can see that actually the granulomatous nodule is at the insertion of the lateral rectus. So we had to be careful while dissecting the nodule and trying to get the suture out. And yeah, surely enough, there was a suture lying there. We did get it out. And so basically my take-home message for these 3 cases has been that you need to trust the patient's history, interpret it in keeping with what you've seen on the slit lamp, investigate and explore every potential infective scleritis as a possible foreign body sitting inside there. Because I practice in an area which has a lot of rural population coming to us with these problems. Probably I'm seeing more of them, but we have an undocumented series of at least 6 cases which I have seen over the last 1.5 years where we have found a foreign body in all of these nodules. So the principles of treating these cases remain the same as infective nodular scleritis. You deroof, you treat the infection, you treat them for long. Microbiology, unfortunately, for the first 2 cases has turned out negative for me, but always have microbiology backup so that in case you don't, things don't go according to plan, you have some other clue. And I would like to rule out everything once again from the beginning before I plan any immunosuppression. Thank you.
this particular case are Dr. Rama and Dr. Bhaskar. Dr. Rama, the first and the last case, the first case especially, the appearance also looked more like a granuloma. The second one was definitely confusing. It did look like nodular scleritis. Did you also think so? What would your differential have been when you see these?
Before that, Devyani, I would just like to know what was the foreign body that was picked up in the first case. And the second question I have is that you're saying the skin surgery was done long ago. Is there any reason that the patient should develop an inflammatory response after so many years? Do you think there was anything in particular?
Ma'am, for the first question, so even in the first case, I don't have the photographs, but even in the first case, we were able to find a sliver of a vegetative foreign body, like something like a twig or a thorn, probably. Not really sure, but it was definitely not something that would confuse about, because it was a very clearly a thorn that was sitting there.
And in the third case, because the surgery was done long back, I really cannot figure out an inciting cause at this point of time after so many years with this kind of suture. Anyway, this is secondary. I think the point that I would like to stress here is when you have a vague history of trauma and you're suspecting a foreign body. Say in your second case, it was a sharp foreign body. So we do understand that it could have entered the eye based on the angle at which it enters the eye and the intensity with which the foreign body hits the eye. Whereas in the first case, forget the third case because we really don't know exactly what it was. In the first case, probably what happens in these eyes is if there is a RTA or fall, there's a little bit of conjunctival abrasion that may have happened, which would have lodged the foreign body in the conjunctiva. With time, with intense eye rubbing, possibly the foreign body got a little deeper. I'm not very sure if all these foreign bodies were in the sclera or episclera. I feel they may have been in the episclera or scleral junction. Because normally when you have foreign body in the junction, you can have a reactionary edema either way. So you can have inflammation in the sclera, you can have inflammation in the episclera as well. The point taken, because now I think we should, now that you presented these cases, we probably also have to consider a foreign body granuloma as a differential diagnosis like what Radhika has asked. Pyogenic granuloma is one. But when you do an ASOCT and UBM, probably you will get a better idea now that we have these investigations in hand. The second point I would like to make is I think when you have a localized edema like this, be it episcleral nodule or conjunctival nodule or scleral nodule, we can narrow down a differential diagnosis to only 2 or 3 conditions. Let us see if this can be a part of a systemic collagen disorder or a vasculitis. Unlikely because you don't have the systemic history. It's not going to remain the same for so many months, and with steroids and possible immunosuppression considering or topical steroids, it didn't really respond the way it had to respond. So we're probably looking at something which is more local to that area. So one could be a foreign body like you have demonstrated. So if you have done an ASOCT, even if you don't see a clear foreign body, if you see the hyperreflectivity and the back shadowing, maybe you can think of it as one of your differential diagnoses. Now what happens if you don't see a suspicious foreign body? What can be the next differential? I think the second differential in a localized nodular scleral nodule could well be an infection, but we're not talking about the fungal scleritis, which will not remain quiescent like this for a long time. We'll have other anterior chamber findings that can come along with it, and with steroids it may initially be alright, but will definitely tend to worsen. So we probably can consider tuberculosis as one differential diagnosis, because trauma can be an inciting agent for the organism to enter, or it can be just a local presentation of a systemic disease which has remained quiescent, response marginally with steroids but never goes away. So I think we should always keep this as a possibility in the back of our mind. Again, with the proper history, if history is not conclusive and the tests are not supportive, then we may have to consider a biopsy in these cases. I'm not looking at myxoma as a differential because I think you have a clear history of a vague trauma and it's a localized lesion, it's not the age maybe. Then the last point I would like to say, although it's very rare, is there are reports of episcleral conjunctival nodules with caterpillar heads which have been described. They are very rare. Normal course is that it attacks the cornea and then it goes into the anterior chamber. Because of the eye movement and toxicity, it enters inside the eye and causes vitritis, and that's the normal course. But having said that, without an anterior chamber corneal involvement, just with a conjunctival involvement or episcleral involvement, through the sclera, it has been demonstrated by UBM in the sclera also, these have actually entered into the eye and cause severe inflammation. So I think it's important that you keep that as a differential. UBM may help to some extent, at least to locate one or two eyes, if not all of them. And as far as the management is concerned, you have very good exploration of the wound. It's very important. But if you're looking at a foreign body, when you're doing a surgery, as you said in the first case, there was a little bit of first point. Maybe you may want to consider sending the material, like you said, for microbiology. And the other important point is make sure that you've removed the entire formant, because sometimes it tends to break when you're opening up the area, and you may have missed out a part of the foreign body. So there may be multiple foreign bodies which, because UBM is not very conclusive in one or two of your cases, so you have to be 100% sure that you've explored the area completely, all the foreign body that is possible. But again, if there is no response after removing, then we may have to look at other possible causes as well.
Ma'am, can I ask another question here? So in my second case, after the removal of the foreign body and when the infection part of it has resolved a little bit, there still remains granulomatous inflammatory reaction. And we generally avoid any steroids for infective scleritis because we don't know what infection it is, because I was not able to really get any microbiology. So would you consider starting any steroids for such a granulomatous reaction later, or?
Yes, if I saw a foreign body intraoperatively and you have removed it, and if I see that the inflammatory response is coming down but has not become normal, after I have covered the eye adequately with antibiotic and the microbiology has not shown a virulent organism, I would certainly consider a low dose steroids at least after a week or 10 days. And then if everything is subsiding, then I can increase the dosage of the steroid. It will respond definitely. Unless you have left behind something, that's what I'm trying to say. You have to be very sure that you've removed everything, you have taken care of the local infection. If at all there was any secondary to the foreign body, then definitely you will get adequate response.
Also, Devyani, I take exception to your mentioning that we don't want to start steroids for any infective scleritis, because out of this context, for herpetic scleritis or for Candidobacter scleritis, we will start. So basically, scleritis where the immune component is as much or more than the infective component, we do start, except probably where rarely fungus because of thorn and all that has caused the scleritis. So we could apply the same principle over here. And since the inciting factor is produced in inflammation, you remove the inciting factor, cover with antibiotic, and then you take care of the inflammation as usual by giving the steroid. We could apply the same principles of a corneal ulcer here also is what I think. So we also have with us for this case, Dr. Bhaskar. Pardon? You want to say something, Rajesh?
Yeah, one point I wanted to make. I looked at the three cases and I would not have labeled them as scleritis at all. I think the foreign body, it would more fall under the category of a conjunctival granuloma or the episcleritis, a chronic granuloma. Because if you look at the anterior segment OCT, the underlying sclera seems to be of normal thickness. And also when the last case, when she opened up the conjunctiva, the underlying sclera did not show significant inflammation. So it also depends on what suture material was used. So as long as the suture material is buried under the conjunctiva, it does not incite any inflammation. But if any end of the suture protrudes through the sclera, through the conjunctiva, then it starts inducing a suture granuloma at that point. So I think it's important what you label. I am not kind of convinced that I would label them as scleritis at this point of time. These are more in terms of conjunctival granuloma or chronic episcleritis. And if it has not shown any infective element, I would not hesitate to use steroids, which would definitely lead to faster resolution of the condition.
I do agree, because I think when you have these foreign bodies, it's very difficult unless there's an intense trauma for it to actually reach the sclera and cause scleritis kind of a
True.
So most of them actually look like at the most an episteral involvement to me also.
I kind of agree. Because first case alone, I actually had to incise the sclera and get the pus material and the body out. While the other two cases, they were more on the level of the episclera. I agree.
And look-wise also, I thought maybe, you're the best person to design because you've seen the patient actually, but they look like little, granulomatous in appearance rather than a diffuse mound which you will get in a scleritis, even in a nodular scleritis. Okay, in the interest of time, we'll move on to the next discussant of this case, who is Dr. Bhaskar Srinivasan. Bhaskar, as all of you know, does everything in cornea. So, Bhaskar, the ASOCT which Devyani has employed to diagnose this case very well, I should say, because the last case you were able to pinpoint that suture beautifully, which by the way I thought has migrated, and when it actually protruded out, it started causing the symptoms. Sometimes we see when we cut sutures on a corneal graft, they retract and go inside. At that time they don't cause any problem, but with time a cut suture migrates outside on top of the ocular surface, and that's when it triggers the problem. I think it's the same that happened here. So sorry, that was digressing. So Bhaskar, what do you think is the role of OCT in these cases? Because it's a very good tool, but sometimes it's got its own drawbacks. The shadowing which she showed could alert us to a foreign body, but we saw recently in a case which was a cyst that the OCT light waves penetrated through the cyst fluid very easily, but the hard wall of the cyst caused backscattering, and that caused a very high reflectivity, prompting us to think that it was a foreign body. So that happens very rarely, backscatter related hyperreflectivity. So how do you think OCT should be employed and interpreted in cases like Devyani's Bhaskar?
Good evening, everyone. That was a very well investigated case, I would say, because pointing out those small foreign bodies, clinically suspecting them, and then in the OCT trying to go through all the cuts, because when it is such a small foreign body, sometimes it is very difficult if you don't look at all the cuts of the OCT to see what you are looking at. So making sure that you tell your technician to give you the cut through the area that you are specifically looking for, or going and making sure that you see through the entire layers. Now, coming to scleritis or episcleritis, it is still primarily a clinical decision. OCT does aid to a certain extent, but how does it actually make a difference clinically in your practice? I don't think it makes a huge difference. What we get in OCT is an increase in scleral edema with scleritis, and a slight increase in episcleral edema, and not much of scleral thickening as far as episcleritis is concerned. But clinically also, most of the times you're able to make a difference. The benefit comes when you have a nodule. One, to know how the conjunctiva over the nodule is, because the other differential which could be there if it's an older patient could even be a nodular OSSN which has been reported as such. Obviously, the patient will not have pain. So when you do an OCT, it gives you a reasonable idea about how the conjunctival epithelium is, what is the level of the lesion that you are looking at, and the edema which is there in the surrounding, whether it is in the episclera or in the sclera, which tells you some idea about what you are dealing with. Whether it is probably a lymphoma, whether it is probably an abscess which is there. But again, you cannot get a definitive diagnosis based on OCT alone, because if you have a fluid collection, it will still show it as a hypoechoic space. Backshadowing will happen when there is any pigmented structure there. So if there is a pigmentary lesion there, you will have a backshadowing. Similarly, if you have a foreign body which is pigmented, you will have a backshadowing. If you had a glass foreign body, you might have actually not. You might again have seen a backshadowing, but it might not be as obvious as what you are seeing with a pigmented thorn that you showed in your first case.
But then glass might have remained inert also. It might not, unless it migrates, it might not have produced this kind of reaction unless there is chemical.
Partly outside, it will again inside changes, which will probably be more in the lids, that you'll see the abrasion on the undersurface of the lids. The only thing is this: all the three patients, when you're looking at the nodule, it doesn't give you an idea of scleritis per se, because the surrounding sclera looks reasonably okay. So when you're looking at when you call a patient scleritis or episcleritis, generally the area of inflammation is going to be a little bit more, at least the surrounding area should be inflamed. There should be some response to the topical steroids that you are giving, whereas here you're seeing three isolated nodules. So when you're seeing three isolated nodules with pain or without pain, you need to start thinking of other differential diagnosis which could present similarly.
Right. Dr. Rishi is also an OCT expert. Just when the lockdown started, we heard to various OCTs being described by him. So what is your take, Rishi? Do you want anything to what Dr. Rajesh and Bhaskar have just said?
I think the cases were beautifully documented, and everything has essentially been covered. But yes, I don't have a UBM, and so if it was in my clinic, I would only have done an OCT. But if I wouldn't have got anything on the OCT, then I would have sent the patient to some place which has a UBM. UBM is certainly better in terms of penetration. If your light is not going to go through, then you're not going to get much information from an OCT, or maybe only superficial information. But I think in that particular case where you got the shadowing, that actually was very useful, and that you may not get in the UVM. So very well documented, and I think perfectly managed.
Right. Moving on to the next case, we have Dr. Sumana Chatterjee. Sumana earlier this year published something on viral conjunctivitis, which caught the attention of the cornea community. But that is not what she's going to talk about now. That entity is going to be discussed by somebody else later. Sumana is now going to talk to us about harnessing the effects of topical chemotherapy for ocular surface squamous neoplasia. Sumana.
Sumana ma'am, kindly unmute yourself. Yeah. Can you hear me? Yes. Okay. Okay. I am humbled for this opportunity to present on this special day, and my today's presentation is about how we can utilize the allied force of mitomycin C and interferon in special situations. Just 1 minute. Not okay. Yeah. So elaborating on the regime, the target group of these are patients who were intolerant to MMC. So we started 0.04% MMC 1 week on and off regime with punctal occlusion. Duration was maximum 4 cycles, or when they developed intolerance to MMC, not manageable with steroids and lubricants. This was followed by 1 million international unit per cc in interferon alpha 2b 4 times a day post resolution of the lesion for 2 months. If lesion still persists after 4th cycle of MMC, we started interferon for resolution of the lesion along with minimizing the mitomycin C side effects and to prevent the recurrence. So I will describe 3 scenarios here. This 60-year-old male patient presented to me with this lesion for which he underwent excision biopsy along with cryo, alcohol epitheliectomy, AMG and fibrin blue application. After 6 months, he showed recurrence in almost in the same region, and he was started on 0.04% mitomycin C. During the 3rd cycle of this therapy, he complained of severe irritation, so I switched to interferon and the lesion resolved. After 2 years, a new lesion came up in a different location, which showed signs of resolution with 2 cycles of mitomycin C only, but keeping in mind of his previous intolerance, I switched to interferon RD for full resolution and prevention of recurrence. The lesion has resolved, as you can see. The second scenario is in case of a diffuse lesion. This 90 years old debilitated man with this diffuse lesion for whom I started mitomycin C, but he could not tolerate beyond 2 cycles, though he showed signs of resolution. For him, interferon continued for almost 6 months. The third scenario, this patient was unwilling and also unfit for surgery, and he developed irritation and surface staining after the 3rd cycle. As it is evident from this picture, you can see this congestion there in the inferior part of the bulbar conjunctiva. And so I had to stop the MMC, though the lesion was still there, resolving but still there, and started on interferon, and he responded well, as is evident from the last picture. So while I have chosen mitomycin C as an initial agent, because of its rapid onset of action and faster resolution. Interferon alpha 2b having negligible side effects that can be continued for a long period to prevent recurrences. Interferon to start with shows late response and a bit more costly than mitomycin C. So the whole idea of this twin therapy was to switch to a second effective agent without fighting the side effects of mitomycin C too vigorously for better compliance and utilizing full benefit of chemotherapy. Thank you so much, and I request inputs from my mentors. Thank you.
Still clear, Sumana. So for discussing this, we have with us Dr. Geeta. Geeta is in charge of the ocular surface clinic at Shankar Netralia, and she works in the surface clinic with Dr. Bhaskar and Dr. Shweta. Geeta, what do you think about Sumana's case? The choice of a treatment like this, would it also depend on the type of the tumor, whether it is nodular or diffuse or papillomatous or gelatinous? What is your view on this type of management?
Good evening, everybody. I think that was a wonderful case presentation by Sumana. You have highlighted three situations, and I would like to tell you three distinct points with respect to each of those cases. The first one highlighted the fact that there was a recurrence following surgical excision, despite the fact that you did it along with cryotherapy and alcohol epithelectomy, which actually reduces the risk of recurrence to almost 7 to 18% following surgical excision, which required, there was a recurrence. And then for the recurrence, you used topical chemotherapy. The second case, I think that was the one which highlighted the elderly patient who was unfit for surgery and had ALL. And the third situation, I don't think you can include unwilling for surgery as an indication to start topical chemotherapy, but it has to fit into the other criteria. So when you look at when you will initiate topical chemotherapy in patients of OSSN, I think it's more important to understand the science behind why you're using chemotherapy, and it's more important to triage the patient accordingly into the surgical group or the chemotherapy group, for which it's essential to understand where you will not use chemotherapy. So if you have a situation where your tumor or the clinically appreciable lesion is invading the extraocular ports, if there is an intraocular extension, if there is an orbital extension where clinically it is a stuck-on fixed lesion, this is a situation where you are not going to opt for topical chemotherapy. If you feel that the patient is not going to be amenable to compliance of use of medications, that again is a contraindication to using topical chemotherapy. If you have very small lesion, a surgery is usually preferred. When it's less than 3 or 4 or 5 millimeters, you would prefer to go in for a surgical excision. If you are unsure of your diagnosis, if there is any doubt in your mind that what you're dealing with is not OSSN, or you're not sure whether this is OSSN, again, that is a contraindication to starting the patient on topical chemotherapy. If it's a rapidly growing lesion, and like Dr. Radhika asked, among the various physical forms of the lesion that you see clinically, a nodular form of SCC is again something that you will preferably do a surgical excision for and not chemotherapy. So these are certain situations where you are not going to initiate the patient on chemotherapy, and where you need to decide, are you starting the chemotherapy for therapy? Are you doing it for immunoreduction or chemoreduction, or are you planning to start the chemotherapy for immunoprevention? I mean, these are certain broad guidelines that we normally follow when we decide whether we want to choose chemotherapy or whether we want to choose surgery.
On the subject of combining the two medications, does this list of guidelines that you spoke about now have a similar relevance, or based on whether you do chemotherapy or you do surgery, any chemotherapy can be done in a double manner that Sumana spoke about?
Yeah, I'll just elaborate a little bit on that. In an ideal world situation, if you're planning to use only chemotherapy, considering the fact that you want to maximize effectiveness and you want to minimize toxicity, your first choice of agent will be interferon. and mitomycin comes last because of the risk of toxicity that's involved. But I totally agree with Sumana that the rapidity of resolution is much better with mitomycin than it is with interferon. We have had a fair share of equal experience with using both mitomycin as well as interferon for these patients. Coming specifically to the choice of the chemotherapeutic agent with respect to certain situations, yes, you do have situations where you will use one over the other. If you are using an intraoperative adjuvant chemotherapeutic agent, then that is usually mitomycin C in a concentration of 0.02%, not 0.04 to the excised margins, which normally we don't do routinely because we anyway combine with the cryo and alcohol epitheliectomy. If you're dealing with a positive margin post-operative, and if it is a CIN, then you can treat the patient just like you would treat OSSN. You can use either interferon, preferably give a 6-week cycle, and or you can use mitomycin C. If you have a positive margin in a patient who histopathologically is a squamous cell carcinoma, the ideal way to deal with it would be to go back and excise the margin, again making sure that the excised margin is free of the tumor cells. But you would probably, if required to use a chemotherapeutic agent, prefer mitomycin C over interferon in that situation. If you're dealing with a recurrence in the mucoepidermoid variant of squamous cell carcinoma where you want to use a chemotherapeutic agent, then that is going to be mitomycin C. In patients of xeroderma pigmentosa, if you have had multiple recurrences and you want to prophylactically use an agent for preventing a recurrence, then you are going to have to you can use interferon indefinitely twice a day in these patients to prevent recurrence. And what we need to remember is interferon is immunotherapy. Mitomycin C and 5-fluorouracil are chemotherapeutic agents. So if you have a situation where you have immunosuppression in a patient, because interferon acts as an immunomodulator and boosts the patient's natural immunity to target the neoplastic cells, if the patient's immune system is suppressed, that is a situation where you're not going to use interferon, rather you would choose your chemotherapeutic agents such as mitomycin or 5-fluorouracil.
So in a HIV patient for lifelong treatment, if you suspect that is a high-risk candidate, then interferon may not be a good choice.
For a HIV patient, the choice would be a non-interferon chemotherapeutic agent, but you don't really have to put these patients on prophylactic medications. The only situation which is really not readily available in literature is xeroderma patients, where they are always at a risk for developing these recurrences, where interferon is used twice a day.
Right. So we also have to discuss this case, Dr. Mona Bhargava from Calcutta. She is a senior cornea consultant in SN Calcutta. Mona, what do you think about the twin approach? Have you ever done it, or do you feel that it combines the demerits of both the cost as well as the toxicity?
Yeah, good evening, ma'am. Thank you for this opportunity and taking me back 12 years ago in my memories. And very nicely documented and presented series of cases, Sumana. All of them were very good and nicely managed. So coming to the question, yes, in our the case scenario that we see here, we initially, if whatever we have done till now, initially we start with MMC, that is 0.04%, as Sumana has already described. And in the case number 1, which all the positive predictive factors of recurrence are present, the old age, male gender, a temporal location of the lesion, a raised lesion with a papillomatous appearance, all of them goes in favor of carrying a risk of recurrence. But what I want to know from Sumana, whether the biopsy showed a positive margin on the histopathological examination, and what was the grade of the lesion on histopathology?
No, it was CIN only, grade 1 to 2 CIN. And the margins were not positive, ma'am.
And also, I think to interrupt you, she has explicitly mentioned in her presentation that she would not take this approach for invasive tumor, which also was reiterated by Geeta.
Yeah. So if the margins were positive, then it has been seen that interferon has been shown to prevent recurrences to the level of when compared to a patient with negative positive margin. Actually, interferon has a benefit over MMC when used in patients with positive margins. And if, as rightly pointed by Sumana, initially we start with mitomycin C along with steroids to prevent the side effects of mitomycin C, that is inflammation and toxicity which is seen. And then if the patient is intolerant to mitomycin C, we can switch over to interferon. And even in such cases which we have recurrences, intralesional or subconjunctival interferon has also been seen to be effective. Like given once a month or can be given weekly also, as different authors have shown differently in their articles.
Right. Thank you, Mona.
Another important point is the immune status of the patient. We don't know the immune status, which is very important.
Right.
To know whether the patient was HIV positive or taking any oral immunosuppressants.
No, HIV testing was done for all the patients, ma'am. They were negative.
I think it is not mentioned, we take it that they were immunocompetent patients.
Can I just make one point here?
Yes, immunocompetent.
So I think we need to understand here that when we talk about invasive tumor, clinically there is no way that you can actually differentiate a CIN from SCC. And the resolution that you get with a chemotherapeutic agent is for the CIN component of the tumor. And what is left behind is the SCC part, which then requires a subsequent surgical intervention. So that is when you basically call it a chemoreduction or an immunoreduction before you take up the patient for surgery. The actual invasion of the scleral codes, which are identified by clinical features of the lesion being fixed, or the inference drawn following OCT, that totally negates the indication of chemotherapy in that specific scenario. And when you talk about, one more thing that I wanted to mention to Sumana about her case is you don't have to proactively anticipate that the patient is going to develop toxicity after the third cycle or the fourth cycle of mitomycin C. Once you see the signs of intolerance, if the clinical lesion has still not resolved completely, then you decide about a switch to interferon if that is required. Because what is the principle that needs to be followed is once you see clinical resolution, and if the patient is on interferon, then you need to continue interferon for another 6 weeks in order to make sure that you have addressed any microscopic residual cells which could be present almost to the tune of 18% in the situation. Whereas when you are using mitomycin C and you have clinical resolution, you only need to have an additional 1 cycle, a 1 week on after you have seen clinical resolution. So it's not like you have to continue mitomycin for another 6 weeks or 2 months just because you have reached. So the duration of time for which you will continue the chemotherapeutic agent after you've seen clinical resolution is different for interferon, 5-fluorouracil and for mitomycin C, and therefore you don't have to intentionally switch over to interferon just because you anticipate that this patient will require a 4th cycle or a 5th cycle. If it develops, another thing that you can do is the holiday period is not fixed. It is not that you need to have a holiday of 1 week after you put the patient on 1 week of mitomycin. With mitomycin, you take a call. At the end of 1 week, if you feel the surface is inflamed, the epithelium is still fragile, before you bombard the surface with another dose of mitomycin, you extend the holiday to 2 weeks and give the next cycle of mitomycin at the end of 2 weeks. So it becomes a 1 week on, 2 week off. So you can titrate it. There is no fixed regimen in terms of 1 week on, 1 week off. You can slightly increase the length of the holiday if required, if there are signs of intolerance.
Right. So even though you didn't say it in so many words, I gather that you'd rather use one drug than two, other than absolutely indicated.
Yes, but definitely indicated if there's intolerance.
Right. Okay.
And if there is no sign of a sign of response. So if you have done the other way around, if you have started the patient on interferon and you have seen no signs of resolution till 2 months, then at 2 months you need to take a decision whether you want to switch to another agent like mitomycin or do you want to take up the patient for surgery.
Right. And also when you want to do a chemoreduction for a large tumor also, I suppose you would use mitomycin for the quicker response. There you don't want to sit and wait for
either ways. If there is no scleral invasion on OCT, clinically there's no evidence of scleral invasion, what is preferred in literature is still interferon over mitomycin C.
Depends on the urgency of the surgery.
Because of the more friendly status of the interferon to the ocular surface compared to mitomycin.
Right. So Aditi, at this point of time, do we have anything for our panelists?
Yes, ma'am, we do have. So, what is the response of 5-fluorouracil as compared to mitomycin C and interferon? Any of the panelists would like to take up the question?
I have no experience with 5-fluorouracil for ocular surface neoplasia, but I don't think it's going to be as effective as mitomycin and as surface friendly as interferon. So, in my practice, it's interferon first for chemotherapy, and then if it's not working, then I would switch to mitomycin. The only reason we were not using interferon earlier was it was very expensive, but now it's very affordable. So I think that in my practice, that's the first choice, either for immunoreduction or for immunosuppression or immunoprevention.
In one of the articles, actually, it's a comparison was made between the 5-fluorouracil and interferon in two separate groups, and both were seen to be equally effective, except for the cost of interferon. Both had no side effects, or a little more in 5-FU in that case, but effectivity was same in both of them.
5-FU was more toxic than mitomycin. I would think
not mitomycin, the interferon.
Interferon, okay.
5-FU versus interferon.
Right.
So looking at the current change in scenario, in fact, there is a shift from mitomycin C and interferon to actually 5-FU because it gives you an in-between outcome with respect to toxicity as well as with respect to the rapidity of resolution is faster compared to interferon, and it is less toxic compared to mitomycin C. It is not daily dosing. You have to take into consideration the fact that for compliance, daily dosing is a factor. 5-FU is 4 times a day for 1 week followed by a 3-week holiday. So it's 1 week every month, and usually the average time to resolution is 4 cycles. Does not, ideally speaking, require refrigeration, which is required for both mitomycin and for interferon. And the surface toxicity is less and the cost is less. See, in India, we don't have a major issue with cost with each of these 3 agents. Whereas in the US, for them, because there is an issue with the cost and because it's off-label, because there's an insurance-related issue, most of the literature that you will find will favor the use of interferon followed by mitomycin, though right now there is a slight change towards using 5-FU as your first line, but we also don't have that much of experience with the use of 5-FU.
I have a question for Dr. Geeta. Do you think there could be, since this topic is about combining mitomycin with this in the holiday of mitomycin, would it be reasonable to give interferon if you really want to hit it hard?
Same question in mind.
If you really want to hit it hard.
So it's actually not required because in terms of potency, mitomycin is actually much more potent to target your neoplastic cells than your interferon, except that it comes with that additional factor of toxicity. So the average time to resolution is actually only 3 cycles. And compared to interferon, where your average time to resolution for a lesion is 4 months. And then you have to continue for another 2 months after you have seen clinical resolution. But you don't really have to do a twin therapy in all situations. A twinning is required, a sequential twinning is required only when you have an intolerance to mitomycin. But you don't have to anticipate that you're going to develop intolerance at the 4th cycle or the 5th cycle, because every eye behaves differently, and you always have the option of adding on topical lubricants and topical steroids, and you have the option of increasing your holiday.
Rajesh?
Yeah, I was just looking at the AAO website, and for 5-FU, it says a concentration of 1%, 3 to 5 times daily, but it says a duration of 4 weeks or 2 weeks on and 2 weeks off cycle. As compared to Geeta just now mentioned that it's 1 week on and 3 weeks off.
Yeah.
So wanted to just have a clarification on that.
Every regimen, if you even look at the regimen of mitomycin C, will have a different regimen. There will be some people who will use 4 days on, 4 days off. There will be some people who use it as 1 week on, 1 week off. But what is generally practiced, especially with 5FU, now the latest regimen that is being practiced is 1 week on, 3 week off. So it's a monthly 1 week cycle. You can
but
have
why do you need 3 weeks off if it is less toxic than mitomycin?
You can have different regimens. You can have the holiday for 2 or 3 weeks before you start the next weekly cycle. So it's not a stringent 2 or 3 week, but it's just to improve the compliance.
What wanted to find out, why do you look at a 3 weeks off?
We have, like I said,
because
we personally don't have
after a week for a week off because we have the toxicity. No, I'm just trying to understand that why do we give, because once you have initiated for a tumor, you want to treat with a medication, then by giving a 3 week gap, you are allowing the cells to recover the malignant cells. So I would rather have therapy.
It's not strictly 3 weeks. You could have a holiday of 2 to 3 weeks before you restart the 1 week cycle.
Similarly, for the response versus the recovery of the inflammation
of the surface, yes.
Right.
Because we don't have personal experience with 5FU, but this is a personal communication that I have had from Dr. Karp, who basically has now shifted to 5FU as her first line of treatment, where this is the regimen that she follows, that she uses it 1 week on and 3 week off.
And on the subject of Dr. Karp, I've heard her referring to mitomycin as the big devil, 5FU as the smaller devil, and interferon as her angel. So that's how she views the three of them.
I would have thought that it would make more sense to have 3 weeks of usage and 1 week off, and then again 3 weeks usage, rather than 1 week on and 3 weeks off. So just make a clarification, whether it was 3 weeks of therapy, 1 week off, and again 3 weeks of therapy, or it's the reverse. But based on literature what we have, I think it will make more sense of a 3 week therapy and 1 week off for.
It's definitely not a 3 week on. It's a 1 week on, followed by you restart the next cycle at either 2 weeks or 3 weeks after you stop.
So basically, these also depend. I mean, not that I'm too great on pharmacotherapeutics, but this probably also depends on the antimetabolite versus the cell cycle. So it may not only be to do with the surface recovery. It may also, I'm theorizing, could be to do with when and how it acts and how long it takes before the next cycle can start. That may have something to do with the 3 week rather than the surface recovery, but it's just a conjecture. Right. So with that discussion, we are now moving on to somebody special. We have Dr. Prema Padmanabhan with us, and over and above her many titles, Dr. Prema can be best described as the wind beneath our wings, and her research interest has taken her beyond the point where our clinical interest stops. So Dr. Prema is now going to give us a molecular backdrop of the cancer chemo discussion that we just had. Over to PP ma'am.
Thanks, Radhika. I think this is we are really in for a commercial break right now. So what I want to, all of you, welcome to your popcorn bags as I inflict a little bit of the science behind the interferons with you. It's been actually acclaimed to be as important as the development of antibiotics because of the increasing role they find of using interferons in various kinds of as an antiviral as well as.
Ma'am, could you turn on your video? People would like to see you before you share your slides.
Radhika, I don't have my makeup on, so I think you can stick to the slides. Okay. So, while you can see my slides, right?
We can't see your slides, ma'am.
Oh gosh, wait.
Ma'am, please share the screen.
Yeah. Sorry.
Yeah. Share the screen.
Hopefully, they don't need makeup.
Wait.
At the bottom of the screen, share screen, green button.
Yeah, green button.
Yeah.
Now is it there?
No, ma'am.
Not yet, ma'am. Is your presentation open on your screen, on your desktop?
Yes.
And once you open share screen, do you see it? Yeah, I think it is slowly.
Yes,
I
ma'am.
think we are starting to see it now.
Correct.
Okay, great.
You can see it, ma'am.
Yeah. So while we thought that these interferons have been described and have been increasingly used only in the last couple of decades. And initially we thought they were only type 1 and type 2, and type 1 having alpha and beta, and type 2 is basically gamma. But now to join the party in 2003 or so, there's a type 3. But rather than go through those, I would confine myself, as I promised Radhika, to only its application in OSSN, where we are talking about the interferon alpha 2b. Now, these are actually a group of cytokines, and they have multiple roles. And the very fact that they have been preserved through evolution, and every vertebrate, there's not a single vertebrate who does not have a gene that encodes for interferons. That should tell you the importance of these interferons in the natural defense mechanism of the body. So each of these have different signaling pathways, but I would stick to the classical one. This is the classical signaling pathway of the interferon as it relates to OSSN. And the thing with these signaling pathways is that they're full of abbreviations which make it look more like an SN duty roster. But I have just highlighted the full names of the ones that really matter. And this is the pathway that we need to be interested in. It's the Jack, you can call it the Jack and Jill pathway, where the interferons actually first bind to the cell receptors and activate what's called the Janus kinase. And this in turn phosphorylates what's called the STAT. It is these two which form the important links to the way interferons work. The STAT in turn activates the gene, well, it forms the transcription factors which enter the nucleus and acts on the genes. So it causes the expression of the interferon stimulated gene, or the ISG. It is this gene, it is the expression of this gene that determines all its functions. And it has multiple functions: the antiviral response, the immune modulation, the cytotoxicity. But in the context of OSSN, we are strictly going to be more concerned about how it does the immunomodulation and how it attacks the cells. Just a bit of trivia: these receptors seem to have a circadian expression, and they express with greater levels seen in the night than in the day. So that would imply that the receptiveness to interferons would also have a circadian manner. So I would imagine that interferons would act better if they are applied in the night time, though I'm not sure if there is any clinical study to substantiate or refute this, but it seems to make logical sense if there is a circadian expression that prefers nocturnal applications. So how does it really have these effects? With specific reference to its anti-tumor effect, it suppresses cell growth. It arrests the cell cycle by regulating the oncogenes and promoting what's called the interferon regulating factor 6. It also promotes apoptosis, and this has actually an important role even in viral, when it's used as an antiviral. It also inhibits cell migration, adhesion, and angiogenesis. These interferons, like Geeta pointed out, act through the immune system. So you know that the immune system has an initial innate immunity and an adaptive immunity. The innate immunity acts immediately with the NR, sorry, not NR. Why do I keep calling NR? The NK cells, the natural killer cells. So the natural killer cells act immediately by being cytotoxic. They also enhance the T and B lymphocytes. They enhance the macrophages, and through the T and through the B lymphocytes, they also produce the antibodies and use the humoral route. So more and more you begin to realize that the approach to treatment of malignancy is going to be more and more through the immunological route than the chemotherapeutic route. I'm not sure if that's actually happening with specific reference to OSSN right now, because from what Geeta says, the 5FU is being preferred by people like Dr. Kaur. But I would imagine that to have an to use the body's own defense to treat tumor cells would make abundant sense. So why is it that some patients stop responding to the interferons, or why do they resist the interferons? And there could be multiple reasons for this. Interferons are kind of schizophrenic. They are double-faced. They could enhance the natural killer cells. On the other hand, they can also suppress the dendritic cells and the macrophages. So it turns out that in the initial part, when they are first used, they are more suppressive in nature. But suppressive in nature meaning suppress the tumor cells. But over a period of time, when they are used for a long time, they backfire and they suppress the dendritic cells and prevent the immune treatment of the tumor cells itself. So that might explain why chronic usage of interferons may not work as well. Also, there is something called a negative feedback. So initially, when during the Jack and Jill signaling pathway, there is a positive feedback because the body wants to produce more and more interferons. But as that happens, it also, now too much of that is also not too good, because too much of interferons will unleash the power of these natural killer cells, and it'll be more toxic. So some of these cells start to have a negative feedback, and these the JAK and the STAT pathways are inhibited, and that may be one of the reasons why it's not as effective anymore. Some of these signals may just be weak, and that might also be one of the reasons why it is resistant to interferons. There could be high levels of VEGF in the blood, and this may be one of the reasons why one of the therapeutic agents is VEGF, anti-VEGF therapeutic agents. You could have tumor clones that resist the cytotoxic environment, and that's something I'm just going to tell you in a minute. And as Geeta said, since it's all working through the immune system, a patient whose immune system is suppressed would obviously not respond to interferons. So much, so they are so interlinked that the presence of OSSN is almost a surrogate for the patient being immunosuppressed. So how does this resistance develop in terms of cloning? This is a little picture that shows you. These are the blue cells are the nice chemosensitive cells, and the red one is the chemo-resistant one. So initially, when the interferon acts through the macrophages and the chemosensitive cells are destroyed, but since they outnumber the chemo-resistant cells, on the whole, the tumor is controlled. But sometimes the tables tilt, and this rogue cell starts to produce interleukins and secretomes that preserve itself. It's a kind of a self-survival mode where it destroys the chemosensitive cells and allows the proliferation of the chemo-resistant cells. And that is one of the mechanisms in which they start to become resistant to treatment. So this, in short, was something that I just thought I would share with you. That's all. Thank you. Thank you for giving me this chance.
Thank you, ma'am. Can you stop sharing your screen?
Yeah.
Right. That was lovely. That was like watching, the actors backstage after a play. And I should say I quite enjoyed that fun about NRN, natural killer. repeating it for the sake of people who didn't quite catch the first time. So, moving on, if there is one thing that the COVID pandemic has taught us, it is that viruses can cause anything ranging from conjunctivitis to convulsions. And we have Dr. Jaya Gupta with us today. No, she's not going to talk about COVID conjunctivitis, but she has, in her usual meticulous manner, worked up a case of conjunctivitis where there seems to be more than what meets the eye. Jaya.
Thank you, ma'am. So, at the outset, I would like to thank Dr. NR and at the outset, I would like to thank Dr. NR and SN for giving me this opportunity to share my case. So, I begin with my screen share. So, my case is of severe acute onset dry eye in adolescent male following presumed Epstein-Barr virus infection, possibly dacryoretinitis. So, my case is a 16-year-old male who complained of red eyes since 2 months. Elsewhere, he was being treated as acute conjunctivitis with several episodes of membrane being peeled off from eyes. There's a vague history of transient swollen lips following oral crocin, prescribed for ocular discomfort much later after onset of ocular symptoms. Medications, he was on oral Acivir, Elpret, eye drop, Sustain Ultra, Gentile gel, and ribapamide from the previous center. My center, he was first examined on 2nd May. His vision with glasses was 612 in the right eye and 636 in the left eye. The NCT was deferred. Slit lamp examination, markedly dry ocular surface with dense filaments was noted. He was unable to open his eyes and a small corneal scar in the left eye was noted. He was started on oral Omnacortal along with preservative-free steroids and preservative-free artificial tear eye drops. I examined him on 5th May. Vision then with glasses was 618. The Schirmers was 0, no wetting. He continued with the treatment. A routine dry eye workup was done and also got an Epstein-Barr virus serology done. That was because my colleague Sumana, as ma'am already mentioned, and here and there I was reading some reports of Epstein-Barr virus causing dry eyes. And surprisingly, his Epstein-Barr virus antibody to viral capsid antigen, both IgG and IgM, was found to be positive and raised. Due to lockdown, Epstein-Barr virus antibodies to Epstein-Barr virus nuclear antigen facility was not there. This I will later explain why this is important. And lacrimal biopsy too I deferred at this time because the onset was 2 months back. He was re-examined on 12th May when the vision improved to 6.9 in the right eye and 6.12 in the left eye. Prior to this, I don't have any supporting clinical photograph due to the marked photophobia. Punctal plugs cautery was explained to the patient for his dryness. And these are some more photographs, some more handwritten notes from his previous center in April, where we can see dense filaments and punctate epithelial keratitis in both the eyes. Again, a fluorescein stained picture to show punctate epitheliopathy in both the eyes and dense filaments in both the eyes. I decided, since he was not willing for a permanent punctal cautery, so I decided to go ahead and do a punctal plug for him. And the one that I used was Vida Plug Flow, which has got a small hole in the end, and this was placed in both the eyes. And 3-4 days later, a week later, this is his clinical picture where he seemed to have improved partially. 27th June, this is his picture. Though better, but the dryness persists. Punctal cautery has been explained to him. He is on topical steroids and lubricants. The Schirmers is still 0. He has resumed his daily activities. Now, the questions or the key points with regard to this case is, what is the cause of acute onset dry eye in this particular adolescent male? Do you think it's only adenoviral keratoconjunctivitis sequelae as he was being treated elsewhere? Or it could be atypical Steven-Johnson syndrome, mycoplasma pneumoniae without any rash. No test was done for this, and I don't think that this was the situation because the lip swelling that he developed was after the onset of his red eyes, or because of the positive serology report that I have of Epstein virus. It could be an Epstein-Barr virus associated dacroadenitis. To summarize, infection by the Epstein-Barr virus may cause inflammatory destruction of the glandular elements, causing severe dry eyes. Viruses can, however, act as a trigger in the development of autoimmunity, that is molecular mimicry. As I already mentioned something about viral capsid antigen and nuclear antigen, I'll elaborate further. Antibodies to viral capsid antigen are detectable with the onset of clinical illness about 6 weeks after exposure. Viral capsid antigen IgM falls to low levels after several weeks, while viral capsid antigen IgG persists indefinitely. Antibodies to Epstein-Barr virus nuclear antigen increase a few weeks after the onset of clinical infection and remain detectable for years. So, the presence of viral anti-capsid antibodies with absent or rising Epstein-Barr virus nuclear antigen antibodies is actually diagnostic of recent Epstein-Barr virus infection. So, that summarizes my case, and it's open for discussion. I asked Dr. Geeta as well as Dr. Shweta to elaborate, or what do they think about it? Was this Epstein-Barr virus serology relevant for this particular case, or it's just a normal adenoviral keratoconjunctivitis sequelae?
We'll have Dr. Shweta as our first discussant for this case. She's the senior consultant in the ocular surface clinic. Can you take your slides down, Jaya?
Yes.
The questions are the same for you, which Jaya has already asked. What are the, even assuming this is a post-viral dry eye, not an immune dry eye, post-viral dry eye, how do we distinguish this from any other post-viral, like, post-adenoviral or post-herpetic? What are the pointers for EBV when you see a dry eye like this?
Yeah. That was a lovely presentation, Jaya. And actually, Dr. Geeta and I had a detailed discussion about this case because it's really interesting, and there are not many cases which have been reported with the Epstein-Barr virus thing. First thing is, since we have not seen the patient in the acute stage, it is extremely difficult to say whether it is adenovirus or Epstein-Barr virus, or was it an atypical mycoplasma. Usually, in an Epstein-Barr virus, in the acute stage, what we see is a dacroadenitis. So there is an inflammation of the gland. There is an infiltration of the gland which causes severe dryness. So you will have some local tenderness in the superior superotemporal quadrant, which, since we have not seen the patient in the acute stage, it's extremely difficult to say. Pseudomembranes is something which goes in favor of adenovirus, but with adenovirus, you would also note some cicatrizing conjunctivitis changes, like, once you peel off the membranes, you would see some scarring of the conjunctiva in patients with adenoviral keratoconjunctivitis. So seeing patients 2 months down the line would be very difficult to really pinpoint, but since you have a serology which says that IgM for the viral capsid antigen is positive, we would still err on the side of Epstein-Barr virus, because IgM positivity does tell you that yes, it is the acute onset. If you would have had the EPNA levels, it would have further, told us, okay, if it is negative test, we are sure that it is the acute onset. But with having an IgM positive itself is a good sign to tell us. As far as your management goes, I think after having 2 months use of oral steroids, I don't know how much it would have really made a difference. But I don't see a harm in giving a course of oral steroids, because it would help reduce the inflammation of the gland if that was the primary source. But yes, punctal occlusion was something that was a brilliant option to give this patient.
I did not catch the part about the test when Jaya pointed out, but is there a role for a PCR test for EBV when you have the membranous conjunctivitis topically?
Jaya, you want to say this?
I have not read reports about PCR Epstein-Barr virus. The only serological reports that I've read is.
So I'm asking you that question. We know that like any other viral detection, PCR is possible for EBV. So is that even a consideration? Would you consider doing a conjunctival swab for EBV PCR in the acute stage? Has it been reported? I'm just throwing the question open.
As far as I have read, I think we can ask Dr. Geeta to take a call on this. But as far as I have read, I haven't read a PCR for a pseudomembrane, because pseudomembrane is usually not a feature of Epstein-Barr virus conjunctivitis that has been reported. But what they have advised PCR is for in immunocompromised patients where they are doing a quantitative PCR to know the number of copies of the viral load. But in an immunocompetent patient, there are no reports. But I think Dr. Geeta can.
So as an extension of the same question, Geeta. So okay, we found out from the serology that this has been proved to be an EBV infection, but we know that both topically as well as systemically the treatment is symptomatic for both the glandular fever as well as the EBV conjunctival infection and the post-conjunctival dry eye sequelae. Everything is going to be treated according to symptoms. So why the bother at all to find out whether it is EBV or not? And what do you think about a topical test for EBV or PCR?
Yeah, so I think let's just break it down into what exactly we are looking at when we talk about dry eye in EBV versus when we're talking about dry eye in adenoviral keratoconjunctivitis. There are two different issues altogether here. And the first question is, in a healthy young 16-year-old boy who's been tearing normally, suddenly in a span of 2 months, you have him coming to you with a Schirmer's of 0. Amongst the entire gamut of diagnoses that you have for anybody with an aqueous tear deficiency, the question is which etiological cause for aqueous tear deficiency is something which can present in a span of 2 months or an acute onset of dryness. That is the question that we need to answer. And for that, you have very few questions. And again, that depends on the sequence of the events and the timeline. What happens in EBV? The cause for dry eye in EBV is a dacryoadenitis-induced EBV, where your lacrimal gland stops functioning and stops secreting the tears into the cul-de-sac because of an actual viral infection of the lacrimal gland. So to actually find a virus in your cul-de-sac and do a PCR from there is probably not going to yield any organism in that case, because the infection is occurring in your lacrimal gland, may get discharged, but if it stopped functioning and if it stopped secreting tears into the surface, then there's a very, very less chance that you're actually going to yield the virus from the ocular surface. In adenovirus, it's the other way around. We see patients who come with tearing when they have the acute stage of adenovirus. It's only post the extensive pseudomembrane related stage, which heals with a scarring of the ductules that are bringing the tears into the surface, that you end up with a dry eye. And the same thing happens in SJS also. It's a scarring of the ductules. So the mechanism of dry eye in these instances is totally different. When the patient comes to you in the acute stage with a dacryoadenitis, you need to know whether you're dealing with a bacterial dacryoadenitis or with an EBV-related dacryoadenitis, because your management is different. That is where the importance of diagnosis in the acute stage, when the patient is having an active tenderness and an inflamed lacrimal gland, which is not going to happen in SJS, which is not going to happen in adenoviral. You're not going to have an inflammation of the lacrimal gland. And you treat with a broad spectrum antibiotic if it's not responding to it, because usually bacterial infection is the most common cause for an acute dacryoadenitis. If it's not responding, you want to know whether you want to treat the patient with steroids to control the inflammation if it's EBV, and EBV is the most common cause of viruses that leads to dacryoadenitis. That's where the importance of serological profiling comes into the picture. when we see 2 months later, because you have now a differential diagnosis that this could be either post adenoviral, it could be post EBV, it could be post SGS because this patient had some minor mucosal ulcerations following the crocin or whatever tablet that he took.
And EBV caused that SGS?
Unlikely. No, EBV is not one of the infective etiologies that leads to SGS, and mycoplasma is the only etiological agent that leads to atypical SGS where you don't have skin lesions and extensive mucosal ulcerations except for your eye and probably 2 lesions in the mouth. So your differentials are very few here. You're talking about either EBV or AKC or SJS mycoplasma, which are basically your differentials, and we put EBV on top because sometimes, rarely, if you have a cicatrizing feature and OCP comes into the picture as a differential diagnosis, which sometimes people do put in as a DD in this situation, considering the fact that this is a very young patient, OCP would be very low in our list of differentials in this situation. So to differentiate that and to not unnecessarily start the patient on immunosuppression or something like that, if you have a positive serological profiling for EBV, it kind of puts EBV as the cause for the dryness in this patient. But as far as treatment is concerned, at this point in time, it is not going to differ whatever might have been the cause. But from the academic and understanding point of view, so the next time when you see a patient at onset who comes with the acute onset dry eye within say a week, you look for presence of tenderness over the lacrimal gland, you have EBV as your differential diagnosis.
But the treatment of EBV itself as a disease is
only supportive and systemic steroids,
right,
which is decided by the IDP.
Right. Okay, in the interest of time, we'll move on before, like Pigman said, our circadian rhythms start setting in. So we have next Dr. Nishant Madhivanan. I have a bit of confusion over here. Nishant, remind me where we are fellows or where you are fellow? So I say this in a good way because such is Nishant's surgical capacity. Such a good surgeon is he. So he would be a good person to tell us that with corneoscleral trauma, how one can minimize the damage and maximize the outcome. Over to Nishant.
Thank you so much, madam. Thank you all my gurus over here. It is because of you all I am who I am today. So why I actually took up this topic after Dr. NR madam said was just for 2 reasons where I found few small points which were very useful. So this was a case which was post small incision cataract surgery, and a blunt trauma was there. The patient came 1 day after the injury. So after taking all this initial workup and test, I decided to take up surgery. The first few important thing is make sure that you dissect each layer individually. So I did not directly go to the tenons. I removed only the conjunctiva over it because to see whether there was any membrane formation or the presence of tenons which were present. Once I removed the conjunctiva, then I went to the next layer where we had the tenons which were under it. So after removing it completely, I actually found out that, as you can see, that there is a membrane. After making sure that as much as possible, try to save every tissue possible. Do not excise each tissue, but try to separate them from the attachment. After separating them from the attachment, it is always easy for our mind to excise the tissue. But being such a huge iris, try to save it as much as possible. So I try to reposition them. You can see it is such difficult to reposition the iris even when I went to the other side. This one point which I realized, which I've actually not seen in either iris tissue repositioning, was the removal of the attachment below the iris tissue. So even if it is for a day, I could see that there were a lot of membranes below. So this one thing which I actually found a little useful, where we always think of the anterior surface. When we release all the tissue from the posterior surface of the iris from the attachment below on the sclera, I could realize that it was a little more freely mobile. Even though that this was such a big blob of iris, with the help of my buds and my spatula, I was able to position it. But as it was near the iris root, it kept coming out. So I actually decided to use one instrument to push it inside, and with the help of the other, take the bite. Always few things about taking the bite is make sure that after you take the first bite at the center, that should be the most important one. So don't take the bite just because to complete it, but make sure that you have adequate depth on both sides. You can see that the iris tissue keeps coming out, but after a few difficulty, I was able to put the first suture, and then I tied it little loose. One more important thing is we can see that the structures are coming out. So do not form the AC, but deflate the anterior chamber as much as possible, because if you inflate it with saline or air, it keeps coming out. And because of the blood clot, the whole anterior chamber was also filled with blood clot. So after putting adequate sutures on sides, make sure that even the suture you are able to use it till the last bite and try to maximize the effect of the suture as well. Always make sure that the plane of suture is parallel to the place where you are suturing. And once I put all the sutures of the corneoscleral bite, I try to remove the blood clot. The blood clot is actually, if you realize that it is more easily stripped away from the angle rather than pulling it from the center. So it was near the angle I was able to pull, and it was able to be stripped easily. And sometimes, if not the Simcoe, even the use of vitrectomy for a thick blood clot is definitely useful for these kinds of cases to remove the blood clot. Too much of pressure might also strip the iris if the Simcoe is held in the port of it. So with a bit of anterior vitrectomy, I was able to clear the blood clot as well. And then finally suture back the place where you were inserted the Simcoe cannula. So finally I would use the fibrin glue to close the conjunctiva and oppose it properly. The air bubble is an indication that everything is perfect and there is no leakage, be it an air or a saline. So my take-home point will be always do a proper peritomy. Make sure that you see the extent of both the sides of the tear. Make sure that the duration of trauma is met, because if it's there for a long time, you have to look for signs of necrosis and infection as well. Don't excise all the tissues without prolapse. The first initial thing is to preserve them, and if not able to, only always think of it as a final term. Vitrectomy, keep it in hand for all these trauma cases, and membrane formation can be all around the tissue and not only anterior to it. Always look for signs of necrosis and infection before you take care. I'd like to thank NR ma'am, all the teachers of Shankar Netralia for this amazing webinar. Thank you so much.
Thank you, Nishant. That was a lovely point there, that the condensed inflammatory material which became a membrane, once you released it, then even that big mound of iris, you were able to push it back, and you did use the iris depositor like an extra finger to kind of, pushing it in while suturing it with the other hand. So as the first discussant for your case, we have Dr. Sudhir. Dr. Sudhir is a senior consultant with our department, and he's also the champion of EMR in Shankar Netralia. So Sudhir, what do you think for this kind of a large iris prolapse? Would it even be required to keep the backup of a scleral patch graft, or because it is a fresh and an incised wound, approximation is possible and a backup of sclera won't be required? Would your steps be any different from Nishant's?
Yeah, Nishant, it was an excellent judgment and excellent case. One important thing which whenever we see iris prolapse, one we need to look at is it looks like a mushroom. Okay, the stalk from which the iris is coming up will be very small most of the times. So what you did is very correct. You went layer by layer and then separated all the tissues. So the last thing which you did was going on the posterior surface, because once you identify, because it will always mask the wound of entry to which the iris comes.
Yes, sir.
So that's the most important thing. So most of the cases in trauma, what time we take for handling the cases to identifying the tissues, identifying the planes and separating them, and then suturing is much faster after once you've done a clean job. So as far as the excision is concerned, I have basically look at how good is the iris tissue. Is it devitalized? It is completely feathery, or it's depigmented, or if it has a lot of foreign bodies, or it's as epithelialization, then and if it is more than 24 hours, probably we need to excise all these tissue. Otherwise, I would try to preserve as much of iris tissue as possible. So in the take-home point in this case is always any iris prolapse, not only due to trauma or due to even in case of rheumatoid arthritis with a perforation, you see a big pop of iris coming out, generally the perforation site is very, very small. So I would go step by step, and then once you have all the correct, I don't think a scleral patch graft is required in this case. You have done a proper management.
Right. So, continuing from where Dr. Sudhir left, Dr. Rama, if the same case presented very late, these days we probably don't go by how many hours the iris has been outside rather than how the iris looks. So, like Dr. Sudhir said, we save as much of iris as possible. But suppose it is a very old injury, say comes to you after 10 days or 2 weeks, and the iris is obviously devitalized or infected or looks necrotic. Then removing such amount of iris has its own share of problems like dialysis, hemorrhage, hole formation in the retina and everything. So what would your tips to managing a case like that be?
It's a very nicely managed case. I think a couple of points from what was already discussed in this case is, I think, of course, we'll all take care of the preoperative part about TT and systemic antibiotic and putting a shield in the eye. And intraoperatively, the one point that I want to insist is be very careful with the speculum, of course. And what I prefer to do if it's general anesthesia, I patch the eye, and when they're giving the anesthesia, and then expose the eye very gently with speculum. The point that I'm trying to make is your conjunctival peritomy should be very, very good, number one. Even for a case which is presenting to us after 10 days, like what Dr. Radhika asked us, I think the basic difference will be that when you expose the conjunctiva, you see the underlying iris tissue. Like Sudhir said, you're looking at whether it's necrosed or it is de-epithelialized or is epithelialized or is it contaminated. So in the acute phase, within 24 hours, you don't expect much of these changes to be seen except for an inflammatory membrane, which is probably going to be there unless it's a very virulent organism. Even then, under the conjunctiva, very unlikely that we are dealing with a very virulent organism. So in those cases, like you rightly pointed out, the first step would be, I would prefer to remove the inflammatory material, whether it looks infective or not infective, and send it for a microbiological examination, irrespective of whether we are suspecting infection or not. And then once you examine the underlying tissue, if it is clear and if there's no necrosis, no contamination, obviously we are going to go ahead and put the tissue back. Now, even in the acute phase, like you rightly said, I think the key is to keep the chamber not optimally filled, because that enhances or makes the iris prolapse worse. So you make a small paracentesis at 3-4 clockers away from the prolapse, and depending on the size of the perforation, you probably want to sweep it from periphery to center in a step-by-step manner if it is very large, but do not overinflate with either viscoelastic or air or saline at this stage. Now, coming to the question that Radhika was asking, this is all about the acute stage. The same patient comes to you after 10 days. Obviously, your tissue is definitely not going to look healthy. I think beyond 72 hours, I would be a little uncomfortable, even if it's covered with conjunctiva, because most of the times what happens is there is a fair amount of epithelialization of the surface that has already happened. So you don't want to really put this tissue back into the eye. So you may, as a first step in the procedure, want to excise the tissue that is prolapsed outside, again send it for microbiology, and then close the wound. The other important step here, especially if it is a 10-day-old injury, after abscessing, after taking the bite, I would like to clear the inner lip. That is where the epithelial cells are sequestrated most of the times. If you clean the inner lip of the wound, then the possibility of epithelial ingrowth, which is the most important concern for you at 10 days, because if it was an infection, by this time you would have had some signs of infection. So you're most worried about epithelial ingrowth. So if you scrape the inner lip, the possibility of minimizing the epithelial ingrowth is pretty high. I think also look at the lens status, retina status, because many times when we are dealing with patients after the initial surgical repair, we don't immediately get these investigations done to find out whether the rest of the eye is alright and what is the next surgery that is required. Extremely rarely, must remember that bleeding disorders are always a possibility, but those are in the rarest of rare cases when there is a positive history. Of course, systemic antibiotic will be required for the initial period of time.
Right.
Thank you so much for all the tips, ma'am. Any inner lip you said to clean? I mean, how do we debride, just with Vexel sponge or scrape it with?
Sponge. You lift the lip maybe and gently scrape the undersurface of both the upper and lower lip, because that way You cannot remove all the epithelial seeding, but to some extent you can actually minimize decrease the number of epithelial cells.
Because these cases, it looks very elegant. The way you put it back looks very elegant, but we have seen some cases which present back to us years later with large iris cysts which arise from the epithelial component of the surface and the iris, which actually fill the eye. Not that tissue should not be reposited, but the cleaning possibly is very vital. So, Nishant, Dr. Rama did talk about follow-up of the patient and visual rehabilitation, and we know that you're also an excellent cataract surgeon. So, very briefly, can you tell us if this patient healed well, then what would be your plan for, cataract surgery, time-wise and technique-wise?
Ma'am, usually if the capsule has not been injured for what this case was, I would actually wait for a month's time to take a topography before I put a lot of sutures. So if the topography is haywire, I would try to release some sutures and see if the anterior chamber is still formed. Once we get a regular topography of the cornea, then the A scan and the K value, the IO calculation is also going to be a little better. As the corneal part is not actually involved, so I think doing a phaco is going to be relatively okay, but the only issue is going to be the posterior synechiae, and I think if we look into that consideration, and if we have particular, the iris hooks for repositing the iris, we are going to go ahead with the phaco.
For the cataract surgery. Right. Okay, since the next case is also on trauma, we'll bring in the panel after that case. So on the subject of trauma, we also know that all effects of trauma don't happen only acutely. Some can happen long term. That is why these patients have to be told that they have to be watched maybe for lifetime. So we have Dr. Sushmita Shah with us today, who's going to be showcasing one such late effect of trauma. Sushmita is a versatile clinician, surgeon, and an excellent speaker. And with her presentation, I can well say that probably we've saved the best for the last. Sushmita.
Thank you so much, Anna ma'am. Am I audible?
Yes,
ma'am. Okay, so before I start, I'd like to sincerely thank NR ma'am and all my teachers and colleagues at Shankar Netralaya for allowing me to be a part of this very interesting webinar. So my patient is a 32 years old male who presented with complaints of a white spot in his right eye of 2 months duration. His unaided visual acuity was 6/6 N6. And
screen is not being shared. Your screen.
Sorry?
Your screen is not being shared.
Shweta ma'am, have you started sharing your screen?
I did so.
At the bottom of your screen, you can see the green button. Share screen. Can you see that? Just click on the screen. See the bottom. There will appear a green button with an arrow.
Get it during the dry run. So.
Yeah, she did.
Really sorry about this.
Yeah, it's beginning to come.
Yeah.
Okay.
Aditi, can you ask the panel a question while she's setting it up?
Yes, ma'am, definitely.
From the chat box?
Yes, ma'am. So, we have a few questions. So, there's a query. Can we use vitrectomy during primary surgery? And if so, then what should be the setting? For clearing hyphema or plaque? Any of the panelists would take the question?
Yeah, vitrector is actually probably the best way to clear a clot if you don't want to kind of remove the entire thing, and if you risk removing the entire clot and having a bleeding, at least if you want to debulk the clot, a vitrector is very useful, and you can use it with higher vacuum and low cut rate setting, just like you would for a capsulotomy if you're using a vitrector. Yeah, you can use a vitrector.
My screen shown now?
Yeah, ma'am, you can start.
Yeah, but your presentation is not visible.
You have to open the presentation.
I think it's the wrong window which is open.
Is your screen sharing?
Ma'am, I would request you to close all the other windows, like all the other things that you have open in your desktop. Just go to the screen.
Is it on now?
Now it's visible.
Correct.
Oh, yeah. Thank you so much. So my patient, he's a 32-year-old male who presented with complaints of a white spot in his right eye of 2 months duration, and he had an unaided visual acuity of 6/6 N6. And slit lamp examination, we noticed a white cystic lesion near the 11 o'clock limbus, which had a conjunctival override, and it also contained whitish fluid, and it was found to be predesmatic in location on anterior segment ECG. What happened? I don't know. Again, it's gone. Rahul, are you controlling my screen?
Ma'am,
you have to go full screen first.
I'm doing the full screen, ma'am. Okay.
Okay. Next slide, please. Yeah. So patient had earlier presented 6 months before, but
slide is not changing, ma'am. Slide is
changing. Yeah, it's
go full screen first.
Mr. Rahul, can you see?
No, first do full screen.
Yeah, ma'am, I'm trying, but it's not going to full screen and not going to next. So please stop share and share screen again and click on first option screen. Okay. Yeah. Now I am stopping your share screen. Okay. Now click on share screen button, and then first option is screen. Click on that and then share. Okay.
Is it coming now?
Yeah,
yes, it's visible.
Try to move it. Yeah.
Sorry about all this. So
not a problem. Go ahead.
So this was a young male who came with a white spot of 2 months duration and had a 6/6 visual acuity. And slit lamp examination, we saw a white cystic lesion near the 11 o'clock limbus with a conjunctival override, and the lesion contained whitish fluid and was noted to be predesmatic in location on anterior segment OCT. A patient had presented 6 months before, but since we had not seen the patient at that point in time, we decided to retrieve his old images from the photography system. And a patient had presented with a lamellar corneal tear at the 11 o'clock, near the 11 o'clock limbus, with an infected foreign body and infiltrates. The foreign body was removed and the infiltrates were treated with topical antibiotics. So based on the clinical picture and the past history, we made a diagnosis of cyst. Now, coming to the management, here was a patient who had excellent visual acuity, but was concerned about the white spot in his eye and wanted us to do something about it. And we felt that we should intervene because we were worried that if we waited, the cyst might increase in size and come into the visual axis and cause drop in his best corrected visual acuity. Having said that, when you intervene in a patient who has such excellent vision, we need to do something which is minimally invasive. So we looked at the options, keeping all these things in mind. So the first and the simplest option is to go ahead and do a simple aspiration, but it almost always leads to a recurrence. We have published that before. The second option is to aspirate the cyst along with chemical cauterization. You can use ethanol or 20% trichloroacetic acid, has all been described with good success in the literature. The other options would be excision and drainage or keratoplasty, but these are more for recurrent cases. So our plan of management was to go ahead with a cyst aspiration with a chemical cauterization with ethanol, because ethanol is more easily available to us. Now, having said that, then again we came across a paper, as I quoted here, Dr. Gogne's paper, where he had used ethanol but reported recurrence of the cyst following single application of ethanol and had to go ahead and do a excision and other maneuvers. So we planned that instead of just giving a simple application of ethanol, we should possibly use it multiple times within the same sitting. So coming to the video. surgery was done under perivulvar anesthesia. So we first did a conjunctival peritomy to look for any occult schiral dehiscence, etc. in that area. Then the localized epithelial debridement was done and all the epithelium in that area was removed. The lamellar tear was identified and the cyst cavity was entered through the lamellar tear with a 30 gauge needle and the cyst contents aspirated. We then irrigated the cyst cavity with 96% ethanol for 1 minute. Ethanol was then replaced with distilled water for 1 minute and the whole process was repeated 3 times. Then we closed the lamellar tear with 10 nylon sutures, not cell-budded. And as you can see, the left side pictures are of the early post-operative period. You can see a resolving cyst both on slit lamp as well as on anterior segment photography, anterior segment OCT. And the right side are the final images showing resolution of the cyst with faint scarring in the cyst area in the peripheral cornea. And there's complete resolution of cyst on anterior segment OCT. And at the final follow-up, we have 18 months follow-up of this gentleman, and he is again 6x6 and 6, but now has a small 0.5 diameter cylinder, and there is no recurrence. So take-home message: penetrating or operating corneal tears may lead to implantation of epithelial cells deep into the corneal stroma. These cells may proliferate and give rise to intercorneal epithelial cysts. Living lamellar tears unsutured may lead to increased chances of such complications, and therefore lamellar tears should be sutured. Intercorneal epithelial cysts may be effectively managed in a minimally invasive way by cauterization with repeated application of ethanol, followed by distilled water, leading to attenuation of cyst and no recurrence. Thank you so much.
Thanks, Sushmita. That was a lovely video. And if there is anything we have learned from epithelial inclusion formation in LASIK cases, we know that an uneven lamellar tear or an epithelial disturbance which is close to the limbus where cells are actively multiplying should always be sutured. If the person who had seen the patient first had debrided that area well and taken a suture, the whole thing might have even not happened, is what I think. And Bhaskar has got some experience in intracorneal cyst management. So what would be your views, Bhaskar? Would you have done anything different?
Nicely, ma'am. Basically, hello. Yeah. Am I audible? Hello.
Yes, Bhaskar. Please continue.
Nicely managed. Probably I would have also done the same. The most important thing in these cysts is basically when the cyst is small and the vision is good. Both the parents and the surgeon is afraid that injecting something in the cyst will actually cause more of a problem. Whereas if you wait and it reaches the visual axis, then it becomes a lot more larger. When you operate and you're trying to do ablate the cyst with chemotherapeutic or these chemical agents, you need the entire lining to be flushed with the fluid. So if the possibility of recurrence basically is because if you're injecting the fluid but the fluid doesn't kill the entire lining of cells, then you will have a recurrence. So if it's a small cavity, you can inject and it will coat it nicely. If it's a very large cavity, like a very large iris cyst or a very large corneal cyst, sometimes you're so worried that if it ruptures, it will go into the anterior chamber. You are hesitant about injecting the amount of fluid, and that actually results in suboptimal filling of the cyst wall, which can give rise to your recurrence. Second thing is, you will have some amount of scar there. Whenever you use alcohol or you use TCA, which was reported by Dr. SKR and Dr. RF and Dr. PP, you will have some amount of scarring which is there. It will take time and it will take a few months or years sometime for that scarring to kind of disappear. So the patient expects, he comes with a white spot and you do a treatment, he thinks that it should go up. You have to tell the patient preoperatively itself that this scarring is going to be there for some time. It will fade significantly. In your case, in about 2 months, it is significantly faded. But if it's more in the center, it is going to affect the vision because it will also cause a little bit of flattening of your corneal contour. Again, this was easier because you had an access to your cyst because of your lamellar tear. If your axis is not seen very easily, then it becomes a lot more difficult because when you go in with your needle, you have to go in and aspirate from the same place, and you have to inject in the same place. So what the shields do is, for an iris is they have the three-way cannula in and they inject and aspirate. But then I found that when you inject it again, you have a lot of air bubble which comes in. So I still prefer coming out and feeling my way through the same tract and going in and injecting. There I would normally start off with my initial aspiration would be with a 27 gauge needle. and my injection would be through a 30 gauge needle so that I'm able to go through the slightly wider tract created by my 27 gauge needle.
I was a little surprised that, even large teresia, when they pull on the cornea, they cause a lot of refractive error, but this big fat thing sitting, almost occupying 1/3 of the cornea, both because of change in the refractive index or because of its physical pull, did not cause any refractive error in this patient. Is there an explanation for that?
Goes down. I had a cornea which doesn't cause that much amount of refractive
change of the posterior corneal curvature does not cause any perceptible problem.
Ma'am, just wanted to ask one or two questions to Bhaskar. Bhaskar, like you lightly mentioned, and I have also quoted the clip from Shankar Netralaya published way back in '98. So there, very
carboxylic acid.
Excellent outcome after 20% TCA. So is TCA still your first drug of choice, or do you use alcohol now as your first modality of this?
I have used, I've had 3 intracorneal cysts where I used TCA because that was available in terms of literature, and we had it our in-house publication. So I followed that. For like for iris cysts, I've been using alcohol now for the last 10 years. And I feel more comfortable with alcohol now. I would probably now use it if I get a new patient. I would probably think of using alcohol. I mean, anything, whether it is TCA, whether it is alcohol, it is basically killing the cell. Point is, it has to be in contact with the epithelium to kill all the cells. So you need to see, so when you're using alcohol, you need to sometimes wait for a little bit of whitening of that area, because that tells you that the toxicity of the alcohol is setting in, which gives you an idea that now your timing is sufficient, which is going to be somewhere close to about 15 to 20 seconds of waiting period. Then you wash it. If you are not sure that you've got sufficient whitening, you rewash it again with the alcohol. Also, it is important that once you have aspirated the alcohol, you need to wash that area with the normal saline, so that there's no residual alcohol or any of the chemical which is sitting there in the cyst space, because that is going to cause inflammation.
Smita, I had a question for you. Yes. That you said this patient was cosmetically inclined, he was disturbed, so you did the surgery. So suppose the patient wasn't, and the cyst was not progressing at all under your watch, then would you still go ahead and do the cyst removal with the chemical cautery? In other words, is there even a threat of melting of the overlying cornea as an indication to do the surgery?
Ma'am, here it was very clear that the cyst was progressive, because we had the 6-month-old picture, and in 6 months we found that the cyst has happened, and it is increased in size to such a big thing that even patient with his naked eye could see. So here he was concerned, and we had to intervene. And but yeah. The issue of whether to intervene or not when the cyst is not progressive is, yes, definitely. If you don't have previous evidence and you don't know whether the cyst is in a progressive mode or not, we can always wait and take photographs.
Because again, drawing from the LASIK experience, we know that an epithelial cell nest, even if it is dormant, it can sometimes affect the nutrition of the overlying cornea. So I'm just thinking whether a parallel situation can happen.
Here, because the cyst was it was in the pre-desmatic stage, so it was like really deep. So whether it would have really caused any effect to the stroma was not a question. Yes, too far away. Just one thing.
The recurrence point which is there, the papers that we wrote back in the late 90s, those were congenital corneoscleral cysts.
Yes.
So these congenital corneoscleral cysts are different from the cyst that you have. Yours is more like an implantation cyst or like a tract. So what we had was ectopic tissues which were buried deep at the limbus, and these proliferated and then migrated into the cornea, creating that plane and resulting in the formation of the cyst. And the recurrence, although whether you use trichloroacetic acid or you use alcohol, most of these cysts have a monolayer of epithelium. So if you use that alcohol, it will definitely ablate. But the problem is the point where it starts. If those cells are not ablated, you get a short effect of clearing the cyst, but then the cells regenerate and then again go back into the cyst. So the point where the cells are generating, you have to destroy that as well. So in such cases, maybe doing a cryo at the limbus to try and freeze the cells and kill the cells of origin. That's also very important. Just like in a LASIK flap, if you don't treat the point from where the cells are going into and you clean the interface, you will again get recurrence of the cells going under that. So So I think it's nicely managed. My only concern would be using a needle, because you may find it difficult to control the needle, and if you would have, a slight movement can also go into the anterior chamber as well. I would have created a track, and then I would have preferred to use maybe a 27 or a 30 gauge cannula to go into the space and then irrigate with my alcohol and everything, because I wouldn't want the alcohol to accidentally go into the anterior chamber, then damage the endothelium. So I think that is where I think instead of using a needle, using a cannula can sometimes be much more useful. So you initiate the track with a needle, and once you feel that you're in the space, rest of the manipulation, use a cannula for that.
Absolutely, sir. Absolutely agree. I think you're absolutely right. But the thing what happened was when I entered I did try with a cyclodalspatula or a dialer and try to go inside, but I encountered a very tough roof of the cyst. So through which once I went into the 30 gauge, then after that there was nothing else would have gone. So maybe what Bhaskar said is, go first with a maybe bigger needle and then go for a smaller needle. Maybe you could have done that. Sure. You would have created a bigger space for the,
And also when you're going in with your needle or anything, always mark your needle with ink. So that when you make a track and then you go back again, you know exactly where the track was, And if you have access to intraoperative OCT, nothing like it, then it's much easier, because then you can see intraop OCT. Although with the needle in place, you'll get shadowing, so you will not be able to see the needle once it's in. You will not see anything behind the needle, but you can always get to the right depth, at least the tip, and then come back and follow it up with a cannula.
Just one comment. I did not mention this in the presentation, was about the cyst aspirate which was removed. So we sent it to the lab. So we were kind of concerned also. We were not sure whether there could be some kind of slow going infection, because it was just a short 6 months history. So we ordered for both a micro workup as well as pathology workup, and then but the report came that there's nothing in the microbiology, but they said the sample was so insufficient that we couldn't do a pathology. So we lost a very important piece of evidence here. And second point is, like sir said, that there is a very clear-cut distinction between developmental cyst and this kind of acquired cyst. So in whatever reports we saw, in this acquired cyst, we need to find where the track is coming from. You have to explore and find it. Unless and until you close that and do something about it, it's going to keep on recurring.
I suspect you would have found devitalized epithelial cells even if you had gotten the material intact.
Yes.
I think Dr. PP wants to make a point.
If I may, I just want to say that it was Rajesh's idea of using a Ventlon and a three-way cannula. It was a brilliant, it was never described before, and as always, I mean, it was his innovation. The word used is marsupialization, and it literally means making it into marble-like. So that's the only way you will know that the epithelium is completely destroyed. So that's what the TCA does rather than the ethanol. The TCA, you can actually see it becoming completely white like marble. That's the term, that's the origin of the term. But I just wanted to tell you how proud I was.
I thought marsupialization is when you de-roof it and you open up the cyst. So if you have a cyst and you de-roof the cyst, then you call it marsupialization. Basically, you have opened it up so there is nothing for the cells to, reform into a cyst. Usually cysts when we marsupialize.
Let me check. I thought it was turning it into marble, but I'll check. Whichever way, I'm proud of what you did.
But what you're saying is right. Compared to alcohol, 20% TCA. What we did was, we didn't know what was the percentage we'll use, so we took a donor cornea from the eye bank, and we made lamellar pockets into that, and then we injected different concentrations of TCA, and then we sent to histopathology to see what is the lateral extent of the damage caused by the TCA, because we were more worried about when you're injecting the chemical into the cyst, whether it's going to spread and damage the endothelium as well. So we found 20% was sufficient, and the Ventlon comes with a needle. So the advantage is you can use the sharp tip of the needle to get into the cyst. Once you're into the cyst, you can withdraw the needle, and then you just have the soft cannula. So you have less chance of perforating when you're manipulating to change to inject the chemical or then to wash it. So you don't have to go back and forth into the cyst.
You squirt it on all directions and you don't injure the lower part. So that's what
I
it
just wanted to have all of you to have an insight into how Rajesh thinks and thinks through a problem from A to Z. Thanks.
Thanks, ma'am.
Any pearls on this pearl in the cornea?
Ma'am, am I audible?
I was asking Rishi.
Yeah, I would agree with Bhaskar's point of going in with a bigger needle first and then for injection go with a smaller. But I would have used a cannula the next time rather than a needle. So that was otherwise a very beautifully managed case by Sushmita, and good that you switched it. So you kind of
great outcome. Great outcome.
Wonderful outcome.
Yeah, well documented.
For Nishant's case, I had one point. Before manipulating the iris tissue which was outside through the tear, I would have made sure I see well what's happening in the anterior chamber. So I would have managed the clot first, and then I would have pulled the iris in after making sure of what's going on.
That has to keep your chamber stable. That works like a plug while you're operating inside.
Yeah.
And also the ballooned iris that you have outside, if you just make a small PI kind of opening that allows the trapped aqueous to come out, then you find that it becomes easier to finish the iris. Otherwise, that's kind of making the whole iris come out. And I prefer to use a dry Vexel sponge for the dissection from the underlying sclera.
Yeah.
So I find that I just pick up a dry Vexel and then I start scraping with it, and I find I can really separate the iris without traumatizing the iris.
And the point made by Dr. Rama is very relevant, that you have to clean the lips to remove any epithelial tissue so that you don't have an epithelial.
And
you can have an epithelial sheet over the iris as well. So sometimes you have to be very
everything
careful before you deposit.
Yes, sir. The PI part will be the anterior part or which part of
it? Doesn't matter. Just
the balloon.
Just make on the balloon. Just make a small opening that allows the aqueous to gush out, and then you find it's easier to reposit the iris rather than trying to push the whole thing in.
Thank you so much, sir.
It deflates the balloon and it goes inside easier. Excellent point. Aditi, do we have any questions from the audience for the panel on these two cases?
No, ma'am, but I did have one concern, if I'm allowed to take.
Absolutely. What's your concern, Aditi?
Sushmita ma'am, excellently managed case. Is she there? So my only doubt was that pre-op, we can see it was pre-prismatic in the asocity. So how to avoid the endothelial toxicity effect and perforation? But I think Rajesh sir has already mentioned a few. But for new surgeons without an imaging, intra-op imaging, how to deal with that?
Rajesh, do you want to take that?
I think what Sushmita was showing in the video is that she first debrided the epithelium to find out that lamellar injury, and then she tried to go through the lamellar injury into the deeper part. So she was using that original track of injury to get into the cyst, and she encountered a fibrotic point where the wound had healed. So to overcome that, she used a needle to enter into that space. When you have fluid-filled space, it's like there is enough space for you to get your needle in. But once you aspirate the fluid and the cyst collapses, then you have to be careful, because with the tip of the needle, you can perforate the posterior layer.
I think her question was more to do with the risk of endothelial injury because of from the alcohol.
The endothelium will get damaged when you inject alcohol. It's not like it's not going to damage, but it will be a very small area in the area of the cyst. And immediate post-op, you will definitely see some edema. But with the adjacent endothelial cells sliding over a period of time, I think your edema will go away.
Thank you.
Any other chat box questions, Aditi?
Yes, we do have.
Checked all of them?
Yes, we do have.
Chat box, can I ask a question?
Ma'am, please go ahead.
Radhika, I just want to ask both Rishi and Rajesh. This is about the OCM. Does the morphology of the lesion, say you have a papillomatous lesion, gelatinous or leukoplakic, between the three, would you decide on mitomycin and interferon based on the morphology of lesion, not the nodular? We know it doesn't respond. Do you think the response is any different if it is papillomatous vis-a-vis if it is leukoplakic or gelatinous?
Well, I don't think my clinical experience post-SN on tumors has been too great, because I don't see that too much in my practice. occasionally, but whatever we have seen, like the ones which are very well defined, we manage them surgically, and the ones which we think we can manage by chemotherapy, we give them cycles of mitomycin or interferon. But again, so I don't have enough experience to look at the three and tell you that one responds better than the other.
Same here. I'm in a very similar boat. I think Dr. Geeta would answer better.
No, I think Dr. Rama herself
Yeah.
will answer that question because she is the active tumor specialist at SN. And ma'am, I think we all accept that it does definitely work in all these three lesions. Leukoplakic patches, I mean, from what experience we have had, might be slightly less compared to the others. And if you have actual keratin on top of the lesion, that might again be a deterrent for a chemotherapeutic agent. But I think you should be the one who should be making the last comment on that.
No, actually, sorry, you wanted to say something, Rajesh?
No, like what she mentioned, if I see a lot of leukoplakia and keratosis and all, then if it's well defined, I usually prefer a surgical excision. Like my tendency to use chemotherapy for those cases are a little less.
No, if we decide on chemotherapy, I think from our experience, what we feel is if the lesion is papillomatous, where the theory behind is that you have a lot more rapidly dividing cells if it is a papillomatous lesion as compared to a leukoplakic or gelatinous lesion, so the response to mitomycin is reasonably good. Whereas in terms of gelatinous or leukoplakic lesion, both interferon and mitomycin takes a fair amount of time. I would even say that I'm a little reluctant if I see a non-papillomatous lesion to start these patients and medications and continue it for a long time because I have a 50-50 doubt in mind whether it will actually act or not. That's why I was asking.
Maybe at SN you should do a prospective trial on using 5-FU and give us more guidelines because it's shown to be somewhere between like mitomycin and interferon. But like I said, we don't have in our Indian context, we don't have any studies that look at it. So do a prospective study, look at it. I think that would be great. Also, anti-VEGF, I think there have been some reports of use of anti-VEGF because they can close down the blood vessels, which are, but I don't know. It's not been very encouraging alone, but maybe in combination, whether it works is something that can be investigated further.
Also, conversely, would it depend on the type of the tumor which is there histopathologically? Whether it is, say, mucoepidermoid or adenocarcinoma, that the response was there or was not there, may also have a bearing on whether chemotherapy would have worked or not.
True.
So whatever studies have been done which have correlated histopathology with the use of chemotherapy, because when we do it clinically, there is no way that you have a histopathological diagnosis. That's one of the biggest flip side or the negative side of chemotherapy, that you don't get a histopathological diagnosis. But studies which have compared the effect and the outcome of chemotherapy with the histopathology, there is not much of a difference except for the mucoepidermoid variety, where you can have a recurrence event post-surgery and where specifically you prefer to use mitomycin.
Right. Okay, then we, for want of time, will draw this engaging evening to an end, and just stay with me for a minute while I offer my profuse thanks to the panelists for their precious time, to the discussants, my department colleagues for their support, especially Dr. Prema and Dr. Rama for their encouragement. I thank each and every one of the speakers for their unbridled enthusiasm, extreme enthusiasm, and Dr. Aditi for ably helping with the coordination, and to the audience outside SN who have bestowed their precious time on us. But it is to you alumni, the younger alumni, that our hearts reach out today, and you have flown high but still retain the roots to stay back with us, and that is a bond that we definitely cherish, and that is an inspiration for the future fellows to come. And our collective gratitude is also to our sponsor Entor, especially Mr. Raman. Hope to have many such simple but substantial sessions in the future also. And I hope all of you enjoyed the program as much as I enjoyed putting it together. Thank you so much.
Thanks to you, Radhika,
Thank you so
for
much
moderating it so well.
Thanks, ma'am.
Nice seeing you, Rajesh. Thanks for taking the time off that you needed very badly in the evening. Sincerely appreciate that. Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Bye-bye.
You should take a picture.